Namaste and greetings. I, Remit Arora, researcher at IMPRI, Impact and Policy Research Institute, Prabhav Evam Niti Anusandhan Sansthan, Nai Delhi, extend my warmest welcome to you all to IMPRI #Web Policy Learning. Today marks day one of Gender and Mental Health, an online international winter school program, a 3-day immersive online certificate training course. This training program is organized by IMPRI Gender Impact Study Center. To kick things off, let's begin with a concise overview of the program. This event is designed to create a dynamic platform for global dialogue and learning on the intricate interplay between gender dynamics and mental well-being. As the virtual doors open to participants worldwide, our aim is to foster a rich exchange of ideas, experiences, and research findings that will contribute to a deeper understanding of the unique challenges faced by different genders in maintaining optimal mental health. Our program features an impressive lineup of international experts, renowned scholars, and practitioners who will share their insights during engaging keynote sessions, interactive workshops, and panel discussions. Participants can anticipate exploring a wide range of topics, including the impact of cultural norms, societal expectations, and gender-based violence on mental health. The program also provides a unique opportunity for networking and collaboration, allowing attendees to connect with like-minded individuals from diverse backgrounds, fostering a global community committed to advancing gender-sensitive mental health practices. The chair for this program is Professor Vibhuti Patel ji, visiting distinguished professor, IMPRI. This program has an excellent panel of experts who will be sharing their expertise for the duration of the program. The distinguished experts for today include Professor M Manjula ji, Professor, Department of Clinical Psychology, National Institute of Mental Health and Neuroscience, Bangalore. Professor Anuradha Sovani ji, Psychologist and Psychotherapist, Professor and Head, Department of Psychology, SNDT Women's University, Mumbai. Professor Mala Ramanathan ji, Professor, Achyuta Menon Center for Health Science and Studies, Thiruvananthapuram. Dr. Aparna Joshi ji, Assistant Professor, Center for Human Ecology, School of Human Ecology, TIS Mumbai. Dr. Meenu Anand ji, Associate Professor, Department of Social Work, University of Delhi. Professor Vibhuti Patel ji, Visiting Distinguished Professor, IMPRI. Dr. Cicilia Chettiar ji, Associate Professor and HOD at Manibai Nanavati Women's College, Mumbai. Dr. Varudhini Kankapati ji, Director and Co-founder, Inner Connect, Counselor at National Academy of Legal Studies and Research, University, Hyderabad. And Dr. Sangeeta Rage ji, Director of CEHAT, Visiting Senior Fellow at IMPRI. The panel of conveners comprises of Professor Gumadi Srijevi ji, Professor, School of Economics at University of Hyderabad, Visiting Professor, IMPRI. Dr. Simmi Mehta ji, CEO and Editorial Director, IMPRI. Dr. Arjun Kumar ji, Director, IMPRI. Proceeding further, I welcome all the participants to this enlightening deliberation and thank you for being interested and putting your time, energy, and effort into joining this experience, equipping you with the valuable knowledge and perspectives to contribute meaningfully to the ongoing discourse on gender and mental health. We've also shared the course outline and reading resources in your email for your kind perusal. Before we start today's session, I would like to remind the housekeeping announcements once again. Please join the meeting on time. There will be a Q&A session after each presentation. Share your questions on the Q&A box. The questions must not be posted as an anonymous attendee. Ensure that your questions are precise. Refrain from making general comments in the questions to save time. Now, without any further ado, let us start our program. It is my honor and privilege to invite the chair for the program, Professor Vibhuti Patel ji, to start the program with the chair's opening remarks. Over to you, ma'am.
Thank you, Ramanathan, for this introduction. Today, we are kickstarting the online international immersive certificate training course on gender and mental health. It is on a popular demand because there has been very great concern about mental health issues in a post-pandemic world. Thank you, Dr. Arjun Kumar, Dr. Simi Mehta, Dr. Ramath, and Ms. Ramath, and Ms. Vaishali Singh, Ms. Vitita, who have put together this course. Welcome, Professor Manjula, Dr. Aparna Joshi, Meenu Anand, and esteemed participants. Now, women and mental health, when we talk about, I think gender is a critical social determinant of mental health challenges. The patterns of psychological distress, psychiatric disorder among women are different from those seen among men, as the material realities impacted lives of men, women, and sexual minorities are different. Women, gender minorities, physically challenged people have a higher level of internalizing disorders, while men show higher level of externalizing disorders. The rates of common mental disorders also occur differentially according to enabling or disabling sociocultural, economic, intersectional privileges or the vulnerabilities. Girls who are victims of child marriage or child labor or transgender child in a school, or a Dalit youth in the higher risk of attempted suicide and self-harm, as we have noticed in some of the apex institutions of higher learning. Interplay of sociocultural factors and gender-specific factors determine prevalence and course of suffering of mental health challenges, and low attendance in hospital setting is partly explained by lack of availability of resources to minorities, gender minorities, women, and other marginalized section. Around 24% of married women in India are reported to be the victims or survivors of domestic violence, as per NFHS 5, NFHS round 5, National Family Health Survey. Family and kinship networks that determine gender norms in socialization pattern, discrimination in schools, stressful life in community and society in general, and gender-based violence in personal and public life, restriction of career choices by parents after marriage, by husband and in-laws, sexual harassment at workplace, customs and tradition that degrade human beings and make them feel unwanted, and children pressurized to perform beyond their willingness and abilities, dehumanizing sex stereotypes that promote son preference, aversion to daughters, and stigmatization of sexual minorities and transgender persons, educated women not allowed self-actualization by pursuit of knowledge, of face mental health problems manifesting in depression, loss of interest in life, feeling of hopelessness, suicidal tendency, and eating disorders. A population with intersectional vulnerabilities such as Dalits, ethnic and religious and sexual minorities, survivors of sexual violence, persons with disabilities, poor and unemployed face discrimination, dehumanization, and exclusion from social spaces that result in acute mental health challenges. Experiences of both industrialized and developing countries have revealed that prevalence of common mental disorders or minor psychiatric morbidity is high among the low income and marginalized population. Women among them are even more vulnerable. So macro forces such as globalization, structural adjustment programs resulting in reduction in social sector fund allocation by the state, increasing conflict with the neighboring countries, ongoing sectarian violence based on caste, ethnicity, communal lines within the country have put population of our country at a high risk of mental illnesses. Women who have to deal with financial hardship experience tremendous stress, and within the family and within the community, they are affected differentially depending on their own place within the India's socio-economic caste hierarchy. The women-headed households, which are managed by widows, separated, single, and women who are facing long-term male migration, also are more vulnerable to mental distress, as they are at the bottom of the poverty line. So respect for gender diversity, plurality, multicultural outlook, and sure, inclusive and accepting environment that promotes mental well-being, as compared to institutionalization based mainly on biomedical intervention and community or family-based support structures based on human touch are far more effective to ensure overall mental well-being. The most important policy tool is the creation of systems and structures that promote intersectional justice through gender-inclusive mental health legislations and rules, data-driven and evidence-based policy intervention, affirmative action backed by adequate funding, clearly defined functions, and competent and empathetic functionaries. For the first time, Government of India has started allocating in the union budget special over 740 crores in 2021, and recently also this current interim budget has also allocated. And first of all, acknowledging mental health as a major social problem, and also understanding the social determinants of the mental health challenges, and providing funds, functions, functionaries to deal with it is it's a welcome sign. And today we have experts, Professor M Manjula, Dr. Aparna Joshi, and Dr. Meenu Anand, who are going to give us an overarching understanding of the problem. Thank you very much. Over to Raman. Yes.
Thank you so much, ma'am, for introducing the program to us. Now I'm delighted to call upon Professor M Manjula ji for an opening keynote address, mapping the intersection of gender and mental health. Over to you, ma'am. Welcome.
Thank you. Thank you, Professor Vibhuti Patel. I think you have given a overview of the program, and almost you have covered most of the topics that will be covered in this series of the program. And I thank IMPRI for giving me this opportunity to give an overview of women and mental health. I'll be sharing the screen. So so my talk is going to be very overview. Like it is, I'm not going into the details of any of the topics that I'm going to talk about today. So the general overview of the gender and mental health that I'll be talking about. So gender, we know that it is culturally prescribed roles to the male and female, and I think it is over the time the roles have also evolved, but still there is a lot of differences in terms of the roles of the man and a woman. So that actually confers a kind of vulnerability for women to experience certain kinds of mental health problems. So mental health, as we understand, it's a state of mental well-being that enables people to cope with stresses of life and at the same time realize their abilities and learn well, work well, and contribute to the community. So this is the overall definition of the mental health, and mental health problems exist on a continuum. Gender is one of the critical determinants of mental health or mental illness. So while there are certain strengths which protect women, or like they are the protective factors in women, but at the same time there are certain factors which make the gender as such a vulnerability factor to develop certain kinds of mental health conditions. So the patterns of the mental illness and the psychological distress are different across the genders. And like the Professor Vibhuti Patel mentioned, common mental illnesses are 2 to 3 times more among women. And the internalizing disorders, like we call these as internalizing disorders, wherein like the symptoms are distressing for the individual, and it is like they're not distressing to the outside world or to the other people, and it is the sufferers are the persons. So that is where it is called as internalizing disorders. The internalizing disorders include, say, for example, somatic symptom disorders, anxiety, depression, adjustment disorders. So most of these disorders, which are also categorized under common mental disorders, come under internalizing disorders. So there are the differences in terms of the mental illness comes from the fact that there are differences in terms of the sex hormones and dysregulation in the hypothalamic and pituitary adrenal axis that happens because of the sex hormones. So especially these contribute to the stress-related psychiatric disorders. So some of the risk factors that confer women the vulnerable, makes the gender as such a vulnerable factor is that the roles that they play. The women play a number of roles, and often because of these roles that they play, the multiple roles that they have to play, the stressors are also multiple. And there is a lot of discrepancy in terms of the social position, status, and treatment in the society, the discrimination that happens in terms of, say, food, education, and the status and things like that. And like I said, they are also physically vulnerable to develop certain kinds of disorders because there are a lot of changes in the hormones that happens across the lifespan at different points in time. So that makes them more vulnerable for depression. Say, for example, the menstruation, the premenstrual syndrome, or the childbirth, then the menopause. So there are a lot of hormonal changes that happens during these times. So they are also like involved in caring for others, including the children and elders, and whatever happens at home. They are the people who take up responsibility. That is one of the other risk factor. And discrimination associated with factors of poverty, like say, for example, the financial independence that they have. So that also actually makes them vulnerable. Malnutrition is something which is a very common thing which is found in women, because they tend to not eat the portions that they eat, or the balanced food that they get. It is after serving all the members of the family. So that is how the malnutrition becomes one of the important factors in women, and especially in the villages. And they overwork. There is domestic violence and sexual abuse. So I am not going to into the details of all these things. These are highly prevalent in our Indian society as well. And there are dowry practices, like, which are maybe more specific to the Indian culture. And there is a firm patriarchal family system, and lesser opportunities for education. The girls do not get educational opportunities. Similarly, employment, and even when they get employed, there is discrepancy in terms of the payment. So, and then negative life experiences and the events are more, because, like I said, across the lifespan, the kind of the stressors that women face are different from the kind of the stressors the men go through. So, coming to the women and mental illness, so depression is a condition which is twice, no, 2 times higher in women. And also it occurs with higher comorbidity with anxiety disorders compared to men. And women will have more atypical symptoms in terms of sleeping more, eating more, and instead of the typical symptoms, like that not feeling hungry, losing weight. So the opposite may be that putting on weight, and these are the more atypical symptoms in women. Anxiety disorders, and specifically generalized anxiety disorders, is also 2 to 3 times higher in women. Bipolar disorder, although it is similar in prevalence, more depressive episodes are seen in women, and the rapid cycling and seasonal patterns are seen in women. Schizophrenia, like the psychotic disorders like bipolar disorders and schizophrenia, prevalence is similar, but then there are some differences in terms of, like I said, the depressive episodes, and when it comes to schizophrenia, they have later onset. So violence against women is found to be around 16 to 50% of the women like experience violence. Rape or attempted rape, 1 in 5 suffer kind of attempted rape or rape. And but then when it comes to the outcomes of mental illness, it is better in women compared to males. But then they experience more stigma, homelessness. If they have mental illness, the chances of them becoming homeless and being abandoned and going through sexual abuse is 2 times more than normal population. And also, women with mental illness are exposed to HIV. So there are higher rates of self-harm behaviors and suicidal attempts. And most often the reasons for the self-harm or the suicidal attempts is difficulties in relationships and the violence that they experience. The reasons for suicide also includes that interpersonal relationships. Often the reasons are interpersonal relationship problems. And sometimes it is the psychiatric and physical illness, like when women have psychiatric conditions, the chances of attempting suicide is more. And like I said, the violence in terms of the violence at home from other members of the family, as well as the spousal violence, is also very common. So about 2/3 of the women in India experience domestic violence. 70% of women between the ages of 15 to 49 years are victims of beating, rape, or coerced sex. So some of the common forms of violence are female feticide, domestic violence, dowry death or harassment, mental and physical torture, sexual trafficking, and public humiliation. So 30% of the psychiatric patients, this is a study conducted on the women who are taking treatment from tertiary psychiatric hospital. So 30% of them experience some kind of sexual coercion and intimate partner violence. So coming to reproductive mental health, so reproduction makes women specifically vulnerable for mental health problems, like I said, because of the hormonal changes that happens, during the pregnancy, before the pregnancy, as well as after the delivery of the baby. So mood and behavioral changes during the pre and menstrual periods. There is a now in India and especially in NIMANS, we have perinatal clinic, and I think in other hospitals also perinatal clinics are coming up, which addresses the difficulties, that mental health difficulties that the women faced before the delivery as well as after the delivery. But then, like, there are mood symptoms that are seen during the menstrual periods also, like premenstrual syndrome. And most women experience symptoms like irritability, restlessness, anxiety, tension, migraine, back pain, sleep disturbances, sadness, and that all these lack of concentration, and there is some amount of dysfunction that happens in the work. So this is a common experience for most of the people. So around 50% of the women experience this, whereas about 20% of them experience severe symptoms that disrupt their functioning. So sometimes they have to take medication. So it is very, very severe. So this takes away around 1 week or so of every month. So most women experience this. So mental health disturbances during the late pregnancy and in the postpartum period are common. And most of the cases, they experience this distress within the 6 weeks in the majority of the cases, that is within 6 weeks of the delivery also. And the prenatal period also, people experience depression and anxiety. So postpartum blues is more common compared to depression. So about 50 to 80% of the new mothers experience postpartum blues, whereas postnatal depression and anxiety are seen in 10 to 15% of the women. So the risk factors for developing depression, like during the perinatal period, is some of them are the social cultural factors that contribute to the risk of developing depression, whereas some may be the hereditary factors also, which can play a role here. So birth of a daughter when a son was desired, or relationship difficulties with mother-in-law and parents, adverse life events during pregnancy, lack of physical help, like the women has to take care of everything, like take care of the child as well as the household work and everything, which becomes very stressful, and especially when they are living in a nuclear setup, or when they are not getting any support from the parents or the in-laws. So systematic review of common perinatal disorders in the low middle income countries shows that 1 in 6 women experience the perinatal mental health problems. So 1 woman for every 3 men attend public health psychiatric outpatients. It means that although they have difficulties, but most often they don't visit the hospital, mainly because that they are not independent, they cannot actually financially not independent, or like they cannot go and seek help independently, because they have to depend on others for taking them to the hospital. Say for example, somebody has to come from a village to the city or to the town for their any kind of a health facility. a man has to accompany them, or it can be a spouse, or it can be the son, or it can be any male person in the family. So generally, they don't visit hospitals also alone. So that makes it difficult, because one, that financially they are not independent, and then they have to depend on other people, other male members in the family, and their health is not given so much importance. That it becomes secondary. Like when a male person has any health problem, then the seeking help is, the probability is much more compared to a female member of the family having any kind of a health problem or a mental health problem. And another reason is that the stigma is greater in women, for women having mental illness compared to male, the man having a mental health problem. And care giving also, like the amount of care they receive also differs, because women receive less support from the in-laws and the spouse compared to the male member receiving the support from their family. So looking at the inpatients also, it shows that about the male versus female, the proportion, 73% of the beds are occupied by male patients compared to female patients. So more than 50% experience sexual dysfunctions, but then do not seek help. So this is in the general public, but when it comes to the hospital setting, more than the women suffering from common mental health conditions as well as major mental health conditions, it is the prevalence of sexual dysfunctions are more than 70-80%. But then nobody comes and talks about the sexual dysfunctions that they're having or the difficulties that they're having. The reasons for that is that it is something which is not considered as important for them. So in our practice, we see that many male patients, like, because of the illness and because of the medications, they will develop certain kinds of sexual difficulties, and then they talk about it. But then women, nobody talks about it. But then when we looked at the prevalence of the sexual dysfunctions or the difficulties, it is, like I said, it is more than 70% or 80% of the women have some kind of difficulties. Yes, to conclude, women's mental health cannot be considered in isolation from social, political, and economic issues, because often these factors, it's a complex in the interaction of all these factors, and we cannot isolate mental health of women from these factors, because these are the major risk factors there. And it is important to incorporate mental, physical health across the life cycle, because the kind of the stresses that they experience differ across the life cycles, and it is very important to address these issues. So otherwise, like, just treating the depression or anxiety is not going to, not going to solve their problem, because they will develop the further, depressive episodes in the future. So if you don't address the social and the cultural, political issues that are contributing to the women's mental health. Risk factors across the broader, like I said, risk factors also has to be, we have to look at all the factors which are contributing. And often we also see that in any health setup or the psychiatric setup, people actually do not look at the factors that are contributing to the mental health of a woman, and they don't actually address. And often we end up addressing only the symptoms of the problem, but not look at, and we are not trained specifically to ask for these factors. And that is where the education, training, and interventions targeting the social, physical environment becomes very important in order to address the women's mental health. So women sensitive interventions at mental hospitals is also very important. Like I said, recently there are perinatal clinics that are coming up, and now we are seeing a number of women availing the facilities, because the percentage of women who experience the mental health problems during the pregnancy and after the pregnancy is very high. and also there are a lot of other factors which contribute to mental health problems, like domestic violence and abuse that happens. And uh, when they attend the clinic during the perinatal period, that is when we realize that there are other factors also that needs to be addressed. So interventions at various levels aiming at both individual women and women at, as a large section of the society is very essential. And it is imperative to improve the criminal justice response to the violence against women also, and adopt strategies that will improve the social status of women. And I think these are all the larger social aspects that needs to be taken into consideration. Uh, and I think women have to take active role in order to um, better the mental health conditions of women. Thank you.
Thank you so much, ma'am, for sharing your insights with us. I would now like to open the floor for a Q&A section. So please drop your questions in the Q&A box, or you can use the raise hand feature. Ramiz Emerji, would you like to ask your question?
Yeah, anonymous attendees are not allowed. Please, you identify yourself.
Yeah. This is Ramiz here, and I'm an educator and teacher educator. So I would like to know that what was the status of mental health and with respect to women pre-COVID, and what's the situation like in post-COVID and maybe during COVID? What was the situation, and do we have any considerable or study that correlates what was the position and what were the key determinants? How we looked at the mental health issues of women and pre, during, and post-COVID. So can
Yeah, so generally, like the post-COVID, there is a increase in generally there is an increase because of in the mental health problems that is seen across genders. I don't think that it is different in women, and maybe like I have to go back and check if there is some literature which compares the men and women in terms of the mental health problems. But I think overall there is an increase in the mental health problems and stress experienced by all genders, like and all age groups also. Uh, uh, and one of the important observations that we could make was that increased marital issues and increased family problems that happened during the COVID and just after the COVID, because of the because people during the COVID they had to spend a lot of time together, and then that is when like all those issues that were not surfacing also surfaced. So yeah, so I don't think there is a gender difference in terms of the mental health problems.
Good evening.
I just want to come up with another supplementary, if you can take it, is that normally we see that men during COVID were mostly indoors, and the kind of attention that a family seeks, taking care of his children and the family, and all the people who really matter to him. So do you think that there could be there is a study or something like that correlate, that helps us understand that what was the situation like when all the men were at home, and women, of course, during those times? So what was the situation like, and what were the uh, uh, I mean what was the actual position of women in those times?
Yeah, so I think the women used to get the time if they're working, like that they get the time off for themselves, and maybe that's a kind of a distraction. Whereas when they have to spend a lot of time at home, and then men, like, they were not at home, and so they could not see many things that are happening, the communication patterns or the children. So they were not managing some of the things at home. Now when they have to manage all those things, I think that also created the stress to them. So that is where a lot of differences in terms of the child rearing and the household activities, all those things became a problem during that time. And like you said, I think the taking care of the elderly at home also was the responsibility of women, and when they have to work from home and take care of other things, so that caused a lot of stress because they could not manage. Since they were at home, they are supposed to manage all the things. I am not sure, like, if I answered. I think I am not able to quote the studies as such, but then this is what I remember reading, some of the articles which talks about these.
Good evening, madam. This is Miss Renu Khandelwal. My question is that though educated woman today is very well aware, but she is not able to practice.
Hmm.
How to make a woman practice after knowing about her rights also, how to make her confident, because whatever problems you have cited, after being educated, many of them have got sorted out, but still the kind of abuse and the kind of violence has changed its shape over a period of time. So how to deal with that?
I think it is the what happens over the time is that they're socialized like that, and it becomes internalized. They take on those roles, and somewhere they feel that it's important, that they have to be responsible, and and they restrict themselves because of the socialization. This is what is expected of me, and this is how I am supposed to be, doing things, or these are the things that I can do, these are the things that I cannot do. So they put lot of restrictions on themselves, and often they don't assert, they because they have not learned to be assertive and to stand for their own rights. So it becomes an internalized thing for them, so they need help actually. So they don't feel confident because they put a lot of restrictions on themselves.
Thank you, ma'am.
Yeah, that is where I think they need help in order to come out of their own restrictions.
Thank you. Thank you.
Thank you, ma'am. Tamagni, Dasti, Chitraji, and Rashmi Sahuji, would you like to ask your question next?
Can I ask my question first? Would you mind?
Okay. Okay. Go ahead. Go ahead.
Hello, ma'am. I was diagnosed with bipolar disorder in 2018, and I had 3 major episodes of mania and the depression. And I had just finished my PhD in political science recently, and then I shifted to Delhi, and then many things happened in my life. And I'm 29 years old woman, unmarried. So I have 3 questions, ma'am. That first one is that will the medicine ever stop or not for bipolar disorder? And the second question is that how can I ensure that I will never get episode in my life ever again, and what precaution I can take? And the third question is that how can I prepare for UPSC? Matlab, I'm 29 years old, and I don't know if uh, I don't know if I am eligible for that to become an officer that I've always dreamed to be, and that's why I'm here in Delhi. And so, thank you so much. That's my question, ma'am.
Thank you. There are two kinds of treatments, and mainly just the medication that you're taking already.
Yes,
And
ma'am. Yes, ma'am.
yeah, so once there are multiple episodes, generally what happens is that that you'll have to take the uh, medication for a longer time or for lifelong sometimes. Like if you have had multiple episodes of either depression or the affective episodes. So that is one, like, you'll have to take the medication for a longer time. That is one. Secondly, there are cognitive behavioral interventions or interpersonal, social rhythms, like IPSRT we call it as, so interpersonal social rhythms therapy. So these therapies will actually help to prevent for future episodes, because they will teach you as to how to identify the early warning signs and what you can do. So I think in addition to medication, um,
Mhm.
the taking therapy becomes very, very important. So you know that how to identify when you're getting or about to
Ye-
get an episode, and then like know that you can um, prevent the episode. So that is something which can be done. I think you'll have to go for uh, psychotherapy. So that is what I recommend. That helps you to keep your mood uh, stabilized. No, yeah.
Mhm, mhm, mhm.
So
And
ma'am,
so should I go for book me? Yes. So
Psychotherapy.
should I go for uh, preparing for civil services at 29 years old woman as a doctor now? I cannot take that much pressure as far as I know myself. So what should what's
I
your
think,
suggestion on that?
yeah, you'll have to look at the nature of the stressors and
Mhm.
what makes you feel stressed. So you'll have to see that, like, that you don't take too much stress, which will actually it is one of the risk factors for a relapse again.
Yeah.
So by now you would have identified what causes more stress to you.
And that's what I should prevent.
Yeah,
And
yeah,
then I can prepare for it, and bipolar disorder cannot be any hindrance in my dreams. What's
no, not at all, not at all.
okay, ma'am. Thank you so much. Thanks a lot.
Thank you, ma'am. The Magni Ji, would you please like to go ahead?
yes. So ma'am, you just mentioned that these perinatal mental health setups are being established in hospital and clinic setups, and women are turning up to avail these services. So does this mean that these kind of positive interventions will actually help women to overcome the stigma, which is a very unique characteristic of gender and mental health concerning women as a population category?
Yes, yes, yeah, of course. I think like the more that they become aware of the things, yeah. One of before I talk about it, it is important to note it is important to note that women like are much more open to seeking any kind of psychological help. They are much more open, and they understand the psychological therapies and psychological nature of the problem compared to men who may not acknowledge the psychological nature of the problem. Women are much more open to any kind of therapies, but then they are not aware of it, and there are other factors which hinder the self seeking in them. But when they come for help seeking, when they come for therapy, they are the one who are much more amenable or much more open about their problem. So definitely once they are aware, they will seek help and they'll get benefited. Yeah,
Hello, ma'am. I am Shivaranjani, ma'am. Can you hear me?
yeah.
Ma'am, actually, this is the modern society nowadays. So, in the modern society, women are facing the mental struggle, ma'am, like domestic violence and patriarchy, something they have facing the thing, ma'am.
Yeah.
Hello.
Is
So
lot of there is lot of disturbance, please.
yeah.
There is a background noise. Please check that.
In the interest of time, we'll move on. Ma'am, I'm just going to read out some of the questions aloud. So there's a question on the different factors contributing to women's mental health issues in urban and rural areas. And then there's another question on do we consider men's mental health or rather mental conditioning specifically affecting gender roles? So when we say to take care of women's mental health and discrimination, do we also consider men's mental health?
Yes. Of course, I think the last question I remember, the previous one I forgot now. Okay, so there is like that gender specific to men also. There are certain things which are higher in terms of prevalence, and there are specific risk factors for men also to develop certain kinds of mental health problems, and they're supposed to be playing particular roles, and when they're not able to play, so that is when they feel very inferior, and then that the stigma is there also for different reasons. For women it is different reasons, for men it is different reasons. So I don't see that like the men are not having any risk factors. They also have a lot of risk factor, and that also comes with the gender specific roles, and there are lots of conditions that are put on men which makes them feel pressurized to accomplish all those things, and if they are not able to, then they feel anxious or depressed. So they are not that they are vulnerable in their own ways. Yes.
Thank
What
you,
is the
ma'am.
other question?
The other question was the different factors contributing to women's mental health issues in urban and rural areas.
Yeah. So I may not be able to list out all the things, but then like in urban areas, especially when they're working, like they have to multitask. Like it is not that they will be they are not taking the responsibilities at home, so it becomes the double the work. Like that you will have to manage this also, that also, and there is no exception, and generally there is no exception.
मैंने अभी बोला तो बाहर आवाज गई अच्छे से क्या?
And for women, the rural women, I think the financial independence, and then the maybe that there are much more restrictions when it comes to rural areas, and then that independence, basically the independence may be much lesser compared to working women in certain aspects. So that way they are also vulnerable. Yeah.
Yes, ma'am. And that's another question on, can you tell me about how modern women are victim by individuals, family, and society? And there are multiple questions on the various kind of stigmas affecting women and why they prevent them from seeking mental care.
Can you repeat the question, please?
Yes. Can you tell me about how modern women are victim by individuals, family, and society? And yes.
Yeah, I think the modern women also, like all the conditions that apply to the previous generations, at least some of the same conditions prevail now also, in terms of, like I said, the gender roles and all those things. And then modern women are like maybe that they are becoming financially independent, but at the same time their responsibilities are not reducing. The expectations are higher, it is increasing on them, and know that they have to struggle to maintain the family, as well as their roles and responsibilities in the workplace, and then like their own internalized conditions that also interfere in terms of help seeking and all that. I think so that makes it complex for them. Yeah.
Then Ojaswini ji, would you like to ask your question?
Yes. First of all, thank you so much, ma'am, for the talk. As a ex-alumni of NIMHANS, it's an honor to listen to your talk. Ma'am, my question majorly is about violence against women. So currently, I'm working in an organization where we work with gender-based violence. Ma'am, the gap between the rural and the urban divide is huge. And no matter what, we are not able to sort of bring that gap any closer. So my question is that how do we incorporate initiatives, or what kind of interventions do you think can actually make an impact to reduce that divide?
I think when it comes to addressing this in the rural areas, one has to study what are the factors, like different maybe the different places it is different, the conditions in their social cultural factors that contribute maybe different. Say for example, in maybe like in South Indian, I'm just giving an example, South Indian village to a North Indian village, and the factors around that, like what are the resources that are available, and what kind of social cultural factors are there. So depending on that, like how they can be made little more independent in terms of their that financial independence, and as well as that how the women can be united together in order to support each other, maybe support networks and some kind of protection against violence. So these kind of things, which is based in their communities and which is to a large extent acceptable in their community. So it is my what do you say, thinking aloud. That is what I'm doing, because I don't have an experience of working with rural women. I think you will be able to add, more.
Right, right.
Yeah.
Yes, ma'am. In fact, Gujarat in 2022 started an initiative called as Balika Panchayat, where they started taking adolescent girls till the age of 20 to be part as the panchayat itself. So their selection is just like a gram panchayat. However, they deal with more streamlined women-related issues. So I think maybe over a period of time we can cover that pan India.
Thank you, ma'am.
I think
Yagna,
Makam also did Mahila Kisan Mazdoor Sangatna. They did a multicentric study on basically interviewing Asha workers and Anganwadi workers who were in touch with women during the pandemic. And they said that massive increase in domestic violence was very much related to attempted suicide, depression, and all the symptoms of mental health challenges that women have. That is there in public domain. You can download that study. Yeah.
Right. Thank you so much, ma'am. Thank you.
From the Makam website, MAKAA.
Thank you, ma'am. Yagna ji, would you like to ask your question?
Yeah.
Yeah. Good evening. Yes, I'm working with Vacha Trust, and we have been working with adolescents and young women for many years. So my question is mainly pertaining to the mental health of adolescents and young women. Is there any particular data that do we see any difference between the mental health issue of women and a specific data on the youth or what we can say adolescents, because their issues are usually different. So just wanted to have some information on that. If ma'am, can you provide it?
There is a lot of material on adolescent mental health. I think that if you search, you will get, and studies from India also, and the adolescent, basically there is a lot of literature on that, and the kind of the mental health problems that they face and the reasons for that, mainly because of the hormonal changes that happens, and then that they are in the stage where they are becoming independent and they want to explore, and there are restrictions from the family, and there are interpersonal, I think they get into relationships, so there are typical issues during the adolescence. So that is different, like that I think it is more or less similar to the boys as well as the girls, similar kind of issues that they face, and they have to excel in their academics also, multiple that domains that they have to work at the same time. So that is what makes them vulnerable for developing mental health conditions, and that is one of the age groups wherein most of the mental health problems are also developed. So that way adolescent mental health and prevention programs become very important during that age group. Yeah.
Thank you, ma'am.
Thank you, ma'am. We'll be taking.
Can I ask a question?
Yes, sir. Go ahead.
I am relatively more with mental health of young adolescents.
Sorry, I
some connection issues. Yeah, Ramat, we can go next.
Yes. Nihalika Yadav ji, would you like to ask your question?
May I ask?
Yeah.
Yes, ma'am. Go ahead.
Yeah. Hi, I'm Chitra, and thank you for your wonderful session. I have 3 questions. Basically, one is, you said that there are postpartum blues and post-natal depressions and all. So if we restrict
Hello,
the...
I think I got disconnected.
Yeah.
Okay, so whoever is continuing, please continue.
Yeah. So if the postpartum blues are, addressed, can we reduce the postnatal depressions? This is first question, which I would like to ask.
Yeah, so postpartum blues is something which is commonly experienced by many women, and generally it may subside by itself also. And a proportion, like a percentage of them, may go on to develop depression. So otherwise, the postpartum blues, that no, it's not a diagnosable kind of a disorder as such. Like no, that is it in terms of the severity, and generally, like no, they overcome also. Whereas depression is it meets all the criteria, so they may require the medication as well as the therapy. Yeah.
Okay. And my second
Ma'am,
question
can I
is,
ask?
you said that women are more open to accept and they are more aware and are open to talk about their mental health issues. But I have worked a lot with the rural and the tribal communities and the tribal women, rural and the tribal women, wherein they are not aware of what is happening. They are not aware. They are out of reach. They do not get any information. They do not know what mental health is. I mean, forget about the mental health. They do not know about their own health rights. They do not know about, they do not consider health as a priority. So, how do we address these issues? Like, one, there is a lack of information, lack of awareness. And then if that woman gets is found to have some mental health disorder, where should she go, and how is that addressed?
I think no, that it applies to many rural areas wherein they are not aware. So not being aware is a common thing. It is for men also, for women also. So I was talking about like that the ability to be able to understand the psychological nature of the problem. If you explain to them, these the women are much more open to these kind of explanations, and they understand what you're trying to say compared to men is what. And help seeking also, that they are much more open once they are, when once they know that this is the kind of the problem, they're more open to seeking help. So you are talking about the basically that lack of awareness is something which is common for certain kinds of social that the rural areas, and which is same for males and females.
Okay. And my
Ma'am,
last
can I ask
question
my
is,
question?
my last question is, do you think that if we sensitize or educate children from the young age on the mental health signs and symptoms, causes, and everything, so will it be able to, will we be able to restrict at a later stage? And has any efforts been taken by the government of India to educate children or to sensitize children?
Yes, there are a lot of programs, no, for that RKSK, and all that for young children, for adolescents. There are programs that are happening, and regularly there are programs that are happening. There are life skills programs. So there are many programs for preventing mental health problems in the RBSK, RKSK. All these are for preventive interventions only. So yeah, there are efforts, and they are useful. They are found to be useful.
Thank you, ma'am. I'll be reading out the
Thank
last
you.
question. The remaining questions will be taken once the remaining speakers are done in the interest of time. So Nihalika G had asked that, ma'am, I was sexually abused when I was a child, and I came from a very dysfunctional and conservative family. And then I ended up being in a very abusive and disrespectful relationship. When I talked about the abuse to my family, I wasn't heard and I was only blamed for it. And I was told not to talk about it as it would not be good for family's name and honor. So, ma'am, enduring all the abuse and going through so much suffering, how should I restore my faith in people and the good? It is very tough to have opinions but not being allowed to voice it. So, how do I deal with it, maintaining my mental well being?
Yeah, so I understand that it's a difficult situation, and no, that is a very difficult experience that you have gone through. Many girls who have undergone abuse at no, the younger age, they continue to have problems even during the adulthood. So one of the important things to do is to undergo therapy. I think otherwise it is difficult, to overcome such kind of the abusive experience, I think you need to seek help. You need to seek psychotherapy. So there are different kinds of psychotherapy which addresses these kind of abusive experiences or traumatic experiences. So I suggest that please take help.
Thank you so much, ma'am, for sharing your insights with us during the session. It was a delight to have you with us, and we hope to see you soon at future IMPRI sessions as well. Professor Vibhuti Patel ji, I would like to call you for your chair's remarks.
Yeah, I think, thank you, Professor Manjula, for examining and also analyzing and convincingly bringing forward social determinants of mental health and also what kind of environment. But my experience is that of women's organization, which believed in a tool of consciousness raising. When we organized a national conference on rape, at that time, all the participants had faced rape or sexual abuse either as children or as adolescent, not only from their family, incestuous, yes, but at the same time by the doctors, by the supervisors in that school, or watchman, or driver, school bus driver, all of them, they had never told anything to their own parents. And many of them, they said, and some of them are extremely well-known feminists, okay, and they first time they confided in each other because non-threatening environment was not there. People, they thought that they would be judged, people would find fault with them, and there would be victim blaming. So I think most important thing is also the creating an environment, non-threatening environment in the community-based counseling where women share the experiences, empower each other, and also see that the fault doesn't lie with you. The person to be blamed is the accused one who did that, whether he is your uncle or relative or neighbor or liftman or watchman. I think that is very important, and the empowering, that would be the one which would get them out of the sense of shame and guilt. No? So that's, yeah. Well, and collective catharsis, it really helped us. That whole conference of 3 days was a collective catharsis, and it acted as a psychotherapy. And all of us felt very this thing that it is a serious social problem, because when a friend of ours, Vidya Apte, who is also in TIS, she is the counselor, and she prepared a beautiful book in Marathi about safe touch and and unsafe touch way back in the 80s. And when we went with that book to the commissioner of Mumbai, he says that, ma'am, your priorities are wrong. If we teach such things to the children, they will lose their innocence. I said, all these children have already lost their innocence. They don't trust anybody. They did not even have confidence to tell their own biological parents. So I think this is what, so they were in a completely denial mode because of the efforts of the women's rights movement. I think now the atmosphere is sympathetic, and now even in the PTA, this issue is being discussed, and parental counseling also happens. Yeah. So thank you. It was really very, very important. Coming from NIMHAS, it also adds the weight, in terms of legitimacy of the program. Yes, thank you.
Thank you so much, ma'am. Thank you so much, Professor M Manjula ji. Now I'm delighted to call Dr. Aparna Joshi ji for an address on making gender-sensitive mental health accessible and affordable. Over to you, ma'am.
Yeah, I was wondering whether the participants will require a 5 minutes break, or is it okay for me to continue? I would love to hear from others.
It's completely okay, ma'am.
Yeah, okay. Fine.
Yes, ma'am.
Yeah,
Thank you
please
so
go
much.
ahead, ma'am.
Thank you so much. Appreciate adult learners. Usually research shows that are not capable of handling any kind of inputs beyond 20 to 30 minutes. And I can see very rich discussion here. So appreciate everybody's engagement. And thank you for giving that permission also. With that, I would like to start my presentation. Just give me 1 second. Hope my presentation is visible and I'm audible.
Yes,
Yeah, I
ma'am.
think it is in working
Yes.
mode. Yeah, okay, now it's fine.
Yes. Now it's all working?
Now
Thank you
it's
so much. So I have, if I understand it correctly, since we are running slightly late, I don't want to eat up into the next resource person's time also, but I'll try to finish within maybe, designated time, leaving some time for discussion also. First of all, thank you so much.
From our side, there is no time limit. Huh?
Okay.
Because the videos are used all over the India, all over
Fantastic.
developing countries. So
So we just
these are the
have to
best resource we are getting. So knowledge resource. From our side, it's not. It's only participants and the next resource person.
Thank you so much, Vibhuti, for reassurance. So I'll keep that in mind, definitely. And first of all, I want to thank IMPRI for even sort of, coming up with this kind of a conceptualization of a program and curating such wonderful sessions also, and giving me an opportunity to be a resource person for this program. So let me just, first of all, I mean, the topic that I'm going to talk about is making gender sensitive mental health accessible and affordable. And I would first like to, talk about my own positionality. Where is it that I'm coming from in today's presentation? And I would also like to talk about my understanding of gender and mental health itself. So I'm an academician working at Tata Institute of Social Sciences. But prior to coming to academics, I've worked in the field for many, many years. And despite my academic and research work at TISS also, I continue to work with communities and be actively involved in service provision. And one of the field action projects called ICOL, which is one of the leading national level technology assisted services in India. I'll share some of those details also, because I can see that some of you may need those kinds of contacts to work with people or communities you're engaging, and sometimes you may require it for yourself. So I thought it may be a good idea to share. So this is where I'm coming from. And I'm also a practitioner. So I see clients for 25 years every week. So I'm also going to draw from my own experience as a client. And I'm also a user survivor of mental health services. I go to my therapist, so I know how it feels to have distress also. My understanding of gender and mental health also, I don't consider gender as binary, where only men and women figure within that. I'm also going to talk about what does gender sensitive services mean? What do they mean for people who go beyond the binary also? And my understanding of mental health is also not from a biomedical, sort of a model. It is also not believing in a discrete model of mental health, which means there are some people who are mentally healthy and some people who are mentally unhealthy. I don't believe that. All of us may experience some kind of a mental health problem, maybe distress, maybe stress, sometime in our life. We lie somewhere on the continuum, but we have the capability of becoming well from ill, but maybe also ill from well. So I think it is very important to understand gender and mental health as continuum. I think Dr. Manjula has made my job very, very easy. And I'm trying to avoid some of the things that she has already covered. But she started with mental health definition that is given by World Health Organization. I just want to, at least at the beginning of this course, since you are taking a course on mental health, at least want to table some important concepts as a student of gender and mental health course that you should be familiar with. I may not have a chance to go into each concept, but some of these concepts, for example, mental health, of course, capability to deal functionally, cope with life, adjust, you optimally utilize your potential. But well-being, quality of life, resilience are also very positive mental health concepts that we should be aware of. And some of the newer concepts also. For example, recovery, which is very different from symptom reduction, which mental health care delivery has been occupied for so many years. Whereas recovery is not just symptom relief, but actually taking charge of your life and recovering from not only illness, but everything that illness must have created as a havoc in your life. Very important concept to remember. Today, mental health is not only understood as mental illness, but also as a psychosocial disability. And this is a different model. Mental illness model traditionally has situated problems within the individual.
maybe sometimes in your brain, maybe sometimes in your biology, maybe sometimes in your psychology. There is psychosocial disability as a concept, and it's very important for gender sensitive mental health care because it believes that my distress is not only a result of whatever is happening within me, but it is an interaction between me and the socio-economic, political, cultural context that I live in, right? So it's very important to understand this interaction. I may have impairment, I may have depression, I may have anxiety, but my anxiety or depression leads to disability because I live in a world that does not understand depression, that always schedules all classes in the morning. My medication doesn't allow me to get up in the morning. So it is the interaction of my illness with the environmental barriers that will create psychosocial disability. And I also want to tell you that mental illness, there is no one mental illness. In fact, Diagnostic Statistical Manual, which is American Psychiatric Association's manual, 5th version, talks about 297 types of mental illness. And with every version, the number of mental illnesses seem to be increasing, which is also sometimes worrisome. That are we labeling normal experiences also sometimes as mental illness? So maybe a good idea for all of us as students of this course to just read about some of these concepts and how mental health itself is not understood unidimensionally, but through different frameworks, right? I think Dr. Manjula has already talked about why are we considering gender. I think first time WHO recognized that gender is a very, very critical determinant of mental health. And she has already talked about some of the concepts, but I just wanted to talk about how did we even arrive at this conclusion that gender is a critical determinant of mental health and what was happening before that also. If you are interested again as students of gender and mental health course, very important to acquaint yourself with this very path-breaking study which was conducted in 1970s by Browerman and Browerman. These researchers did a small task. They went to many mental health professionals and gave them a list of adjectives and asked them that from these adjectives, if we were to ask you to select adjectives that best describe who is a good woman, healthy, mentally healthy woman, who is a mentally healthy man, and adjectives that describe a mentally healthy adult. And it's not a surprise that when mental health practitioners group these adjectives into mentally healthy woman, man, and adult, what they called as mentally healthy adult was similar to what they called as mentally healthy man, which means being independent, being rational, being self-determining, being very in charge or control of your life is only indicative of good mental health. Which means mental health services themselves are very biased when understanding perhaps women's mental health, and they do not understand that women's emotionality can be very much a strength and it doesn't have to be looked at as any kind of a problem. But before gender was called or gender related studies became an important critical determinant of mental health, there was a huge bias within the mental health field which was against women. There were many gender blind theories also that were sometimes theories were saying women are more vulnerable because of their biology and hormones, and sometimes theories were saying that there is no difference between men and women and we should be treating them only as symptoms, bodies, brains, and nothing else. It is, for example, Brown and Harris's work in 1970s with social origins of depression that for the first time we started looking beyond the biology, beyond the hormones. And I'm a psychology student. I don't know whether you've heard about Freud also, who was responsible for coming up with hysteria and how women's, psyches are responsible for their weaker mental health. I think now it is very clear that women's mental health is very much an interplay between biological and reproductive health, but the socio-cultural, political disadvantages that they have to experience when you are living in this world, right? So I just want to sort of talk about why are we talking about gender as a critical determinant and how it was absent as a discourse prior to some of these studies. Yeah. So research has shown that socially constructed differences, and it's not just the biology, it's not just the reproductive health, but it's the social structures which are also responsible. I'll give you one common example. Professor Manjula talked about suicide. Data from India shows that India is one of the leading countries when it comes to attempted or death by suicide. And if you look at the gender differences, men attempt or die by suicide men die by suicide much more, and women attempt suicide much more. But women's reasons for attempting suicide are not biological. They are based on gender-based discrimination, and the biggest reason is violence against women within public spaces, but most importantly, within the private so-called safe homes, right? So very important to understand these socially constructed roles, structures, and how they create certain levels of advantages or disadvantages for men and women. I think to sum up just how gender is a critical determinant, so that then I can move to, if this is the case, what kind of services we need. And I'm just creating a foundation for that kind of an argument. Dr. Manjula already talked about how there is a difference in prevalence or how mental distress manifests in women and men. Typically, you will find men's mental distress manifests through perhaps, substance abuse disorder or aggression, whereas women's mental disorders typically will be internalizing, whereby they are perhaps more in distress internally rather than taking out that distress outside. Depression, anxiety, and there is overwhelming evidence which shows that it has nothing to do only with their biology or reproduction, but it's to do with the life cycle related discrimination and violence that they continue to face. The second difference between binary, I'm right now talking about binary, is related to the underlying factors or stress. If you look at, I think Professor Manjula has gone through life cycle. Even before I'm born, I may be killed, right? Or as a child, we have talked about child sexual abuse. Till the time I die, as a particular gender called woman, I may be subjected to several, 1 in 3 women in India face domestic violence. So we're not talking about some small numbers here. And there is an interesting construct which is given first by Joseph Pleck, 1970s, you can read, called gender role strain, and later on developed by O'Neill, called gender role conflict in men. Traditionally, people believe that men are always, privileged, and they are compared to women in terms of patriarchy. But O'Neill's research showed that men, by adhering to traditional ideas of masculinity, actually do not enjoy privileges in terms of their mental health. It contributes to poorer mental health, which means as a man, you're pressurized to fit into becoming provider, independent, competitive, very aggressive. But by doing the very thing, you are actually causing poor mental health to yourself. So this is a very interesting research, and it has implications that asking men to be traditional men is actually contributing to poorer mental health. Maybe socializing men into different ideas of masculinity, which are far more progressive, is a good preventive strategy against mental distress in men. The next thing is health-seeking behavior, and I'll talk about it much more. Women typically, you will find, in case they experience distress, will go to primary health care centers, will go to traditional healers, will go to perhaps informal care, money, access. Definitely, they will have somebody to carry them. And whereas men, typically, you will find more saturated in tertiary care, mental hospitals, because access, perhaps resources are available to them also. In terms of service delivery issues, also, there is a clinical bias. If a woman cries, if woman shows symptoms of sadness, there is a greater likelihood of diagnosis of depression, anxiety, as compared to the same man who may show symptoms but may not get a diagnosis. So women may get overdiagnosed and over-medicated, but men may get underdiagnosed and therefore may not receive any kind of a treatment also. And one of the last things I want to say, how gender plays a critical role in mental health is, let's suppose, as a result of all of these gendered factors, I have developed mental health problems. As a woman, there is a higher chance, and there are good studies from a Chennai-based organization called SCARF, some of the path-breaking international studies in schizophrenia that show that if women are diagnosed with schizophrenia, they face the social consequences of stigma, desertion, and divorce. But if a man is diagnosed with schizophrenia, they actually have social consequences of being cared for and having received some kind of a treatment also. Why? Because women's caregivers are men who may not feel responsible for their care, but men's caregivers are women and they will ensure that men get care also. So gender is literally affecting every bit of mental health journey for all men and women. Very important to understand that. Having laid this foundation, now we move to what is gender sensitive mental health care also, right? I think if we have to develop gender sensitive mental health care, and I'll also come to what mental health care exists in India and how do we make it more gender sensitive also. We need to, first of all, understanding these unique socio-political cultural realities and then understand mental illnesses or mental health problems, not just biological or reproductive issues, but issues embedded in people's context, number one. Number two, even understanding how men and women access or can afford or approach mental health services will help us understand. For example, if your OPD hours are, let's suppose, morning hours, that's when women cook. That's when women have to get children ready for school. That's when women have to, fill water. Then if you run your mental health services during that time, perhaps if you run mental health services in India, for example, people, in order to get mental health services, have to travel average 10 kilometers. Can you imagine a woman on her own will get a bus ticket and travel? To do that, it's not possible. So she will access whatever is immediately available, cheaply available. It may not be quality, but at least something is available. And I don't want to say that informal mental health care is poor. That's not what results show. I'll come to that also. But so gender sensitive mental health care needs to create design services, design spaces, design training, and design definitely outcomes and consult people when they have to create their services. That is what gender sensitive mental health care needs to do. Having said that, let's see what mental health care exists in India. Yeah, very important to understand. And I'm literally listing it. There are papers written for each of those. So one of the historical programs that India actually boasts about, which is called the National Mental Health Program and District Mental Health Program. And this is a flagship program in which services are provided at the grassroots level, from mental hospitals to community level. Then we have general hospital psychiatric units, which means wherever there are tertiary hospitals, there are gynecology departments, there are MD physicians, there are cardiologists, there is a psychiatrist also. Then mental health services, wherever the government could not reach, civil society organization. I call, for example, the project that I work is a academic response, a civil society organization, the response to whatever the government couldn't provide or reach. The private mental health care occupies a lion's share in terms of, because public mental health care is considered to be free, not of quality, you have to wait there, it is primarily biomedical. Private mental health care continues to, but it's exorbitantly expensive. It's not at all easy to afford it. A new brand of mental health care, which is at least emerging in urban mental health care. And I see a huge change post-COVID. If you are interested, please read actually a report on workplace mental health, which was published in 2022, which talks about how, and policymakers don't understand emotional arguments. They understand economic costs. So when you were able to show that actually not allowing people to feel happy at workplace is actually reducing their productivity, then now workplace mental health is also in place. There are many employee assistance programs which has come up. There are digital mental health services. Technology has become very, very, and post-COVID, there is a boom, sometimes concerning also. It worries me also. And please remember, traditional healing is a very important resource and particularly accessed by women. Many studies from South Asia and India show that 70 to 80% of people suffering from mental illness, not just rural, but even urban, actually have access to traditional healers at least once. And there are impressive researches coming even from places like NIMHANS, which show that traditional healing in some places is capable of treating psychosis also. with better outcomes than even medication. So do not disregard it as a resource and a service in a resource-crunched country like India, right? You see 1 in 7 people in India are suffering from mental health problems. And if you look at the treatment gap, and this is one of the largest epidemiological survey that India conducted in 2015 and 16, which is called the National Mental Health Survey. Till that time, we didn't have that kind of impressive epidemiological data. And this survey shows these kinds of gaps, almost 90% in some parts of India. So when we talk about accessibility, affordability, first let's talk about whether there are services, and there are none in many geographies in India, right? So we can't blame people for accessing whatever they have, and they are making the most of whatever they have, right? So it's a big challenge, but post independence we have come up with some realizations that I mean, similar to Western countries, we cannot afford to have specialist driven services. We have to use perhaps what are, I hate that word, paramedical professionals. They are as much, they are better professionals sometimes than medical professionals. So other professionals have to be actually the delivery persons of mental health care than a few specialists. For almost 170 million people who are in need of mental health services, we have 5,000 psychiatrists, 7,000 clinical psychologists. We can never suffice, right? The National Mental Health Program has very important goal, availability and accessibility of minimal mental health care for everybody. And it does so by integrating mental health into our primary health care structure, which means right from mental hospitals till the PHC, doctors are trained to diagnose and provide mental health services. While it's such a wonderful concept, and now 692 districts in India are covered by district mental health program. Blueprint, fantastic. What is being translated, unfortunately, at the ground level, and which is very disastrous for women particularly, that minimum mental health care for maximum number of people prioritizes psychosis, which has more severe symptoms than common mental disorders such as depression, anxiety, somatoform disorders, dissociative disorders, which actually manifest twice in women and which are related to socio-cultural and violence-related actually stressors, which means you will continue to give only medication, which means you will not give a comprehensive care, which means women will never receive care. Tell me, if a woman with depression comes to a mental health care system, the mental health care will give her antidepressants. But there are no antidepressants that are going to take care of her domestic violence. There are no medications and pills created in any part of the world. So this National Mental Health Program unfortunately omits and actually neglects women's needs and women's realities. So the only program we have is very biased towards severe mental illnesses and may sometimes serve men's needs, but unfortunately does not serve women's needs. And Bhargavi Dawar, if you are interested, again, path-breaking work on gender and mental health in India, therefore says that we need to move from an illness-focused language to a distress-focused language. Women face common mental disorder, which is more distress and distress needs a more psychosocial comprehensive response and not just medication. Very important to remember that. So there is a need for dialogue, not just within medical disciplines, but across sectors, development and mental health, feminism and mental health. And the location of disease cannot be within women, but the location of disease also has to be within the context that women live in, right? Very important to remember that women's help seeking shows that they approach more community-based services, more traditional healing services, more primary mental health services. And men, unfortunately, somebody was asking, why is it that women are more open? See, traditionally, mental health is associated with emotions, vulnerability. Men hate those spaces because of their gendered socialization as weakness, that if I access mental health services, which means I have failed. And therefore, actually, current services are not even accessed properly by men. So we need to, when talking about gender sensitive mental health care, create services which address unique realities of women, but also men. And for that, we need to change our conception of who provides mental health services, where mental health services are provided, And I just want to say that we don't require mental health services only which are symptom reduction. We require preventive services. We require promotive services. Everybody should feel good as a result of that. And we require mental health services definitely, which are actually provided across lifespan, which are rights-based in their discourse, and which are empowering and community-based. We don't require facility-based services. This is a fantastic pyramid. Please read about WHO's optimal matrix of mental health services. It says that any community maximally requires self-based mental health services, followed by informal care, family, community, followed by maybe PHC-driven mental health services, and mental hospital should be the last. But if you read India's mental health hospital surveys, actually that's our primary strategy of mental health care services, and that needs to change. I just want to, I'll start wrapping. I know my time is over. So we require gender-sensitive mental health services which are away from biomedical focus. And we should definitely understand what are the unique realities and barriers also, and accordingly create services. We need to train mental health. None of this is going to happen unless we integrate gender as an important ingredient into mental health curricula also and training also. There is a fantastic paper by Prabha Chandra. If you are interested, I didn't share some of the current readings. I'll be happy, which talks about checklist for how do you understand whether a particular mental health service is gender sensitive from a women's perspective. I'll be happy to share that. It's a good checklist to look at. And some of the last things I want to say that please do not see how to make mental health services gender sensitive, but we need to also see how development programs become mental health integrated also. Now we are talking about domestic violence services, one-stop centers, RKSK. We are talking about school health program, which the government of India launched in 2018. There are programs for migrants. There are programs for youth development. All of these programs have to integrate a mental health component. Mental health services can't be responsible alone for mental health. Development also has to be responsible for mental health and well-being of people. Our policy and legal frameworks also have to be very, very friendly. Currently, there are 200 plus civil and political laws in India which disenfranchise women. So as a woman, if you are a person with unsound mind, you will be easily divorced. Anybody of any gender cannot sign a contract, cannot actually vote, cannot perhaps own a property. We need to look at legal frameworks also. Having said that, the Mental Health Care Law 2017 is a fantastic legislation which is rights-based and user-centered. Very important to look at. And I just want to say that please move beyond the binary also. Gender is not about men and women, right? How do we create services which are accommodating, which are sensitive, which are non-discriminatory, non-abusive to people who do not adhere to binary? And here are a few suggestions. If you are interested, Mariwala Health Initiative has come up with a fantastic resource called Queer Affirmative Mental Health Care. And the entire, I've taken some of these takeaways from their training manual, which is freely available. Very graciously, they have made that manual available. So please look at that. And I just want to say, if any one of you wish to refer people, iCall is a field action project that I've been running in Tata Institute of Social Sciences since past 11 years. It's one of the leading technology-assisted psychosocial service, which is free, but professionally run, completely anonymous. You can visit our website and take a look at it. Thank you so much. My apologies for overshooting the time a bit, but happy to answer the questions. And thanks for your patient listening and for being here in the session.
Thank you so much, ma'am, for sharing your insights with us. I would now like to call Professor Vibhuti Patel to give the chair's remarks.
Yeah. Thank you, Dr. Aparna Joshi, for making such a comprehensive presentation. And also, I think you were checking the questions which were coming up in the dialogue, in the chat box, and you were also taking care of that. But I think most important thing that I liked about it, that service providers, what all kind of support services that can be provided, and also going beyond gender binary. That is very important. We have seen how the sexual minorities or the people who are facing ostracization from their own biological family. And they are the ones who are left out. PUCL report, you must have seen the recently. It is a comprehensive multicentric report which shows the agony of that. And I think that is why in all services, I think it's very important to integrate the non-binary approach. And we need to have more like understanding about the community-based and also the traditional healing. I think that is also because generally it gets always stigmatized, and it is considered to be more of a witch doctory, and it is not even treated as a scientific way by the mainstream medical lobby. But I think in Ayush approach, there is some scope for the traditional healers. Yeah, and it's very, and that area is also under researched. It's a gray area. We need more serious studies and qualitative studies on responses to traditional healing and what are the outcomes of traditional healing. Very important. Thank you very much.
Thank you so much, ma'am. Ma'am, with your permission, could we move on to the next session, and then keeping time in mind, and then we'll come back to the questions in the end. But thank you so much, ma'am, for sharing your insights with us.
Thank you very
having
much.
such an engaging session, and we look forward to having you at future IMPRI events. It is now my delight to call upon, sorry, ma'am. It is my delight to now call upon Dr. Meenu Anand ji for an address on perspective on gender and mental health. We welcome you, ma'am. Over to you.
Thank you so much, Ramat. I want to begin by thanking Professor Vibhuti Patel, Dr. Arjun, and the entire team at IMPRI for giving me this opportunity to be a part of this wonderful winter school program. And gender and mental health is very, very close to my heart. And it cuts across all disciplines. And to see such a wonderful audience here really motivates me to further reiterate and work more on the issue. And I think as human beings, we are constantly exploring, understanding, we are trying to pause, we are trying to halt and review everything from the mental health and the gender perspective. So, Professor Vibhuti, ma'am, how much time do I have?
Go ahead. You are the last one, so you don't have anyone waiting for you.
But ma'am,
participants are very seriously engaged, so that's not a problem. Now you two, you and Aparna will have to answer the questions.
Take your time, no issues.
Take your own time.
Is my screen visible, ma'am?
Yes, it is in working mode. Make it now.
Please go slide.
Slideshow. Make it slideshow.
I'm at top, home, insert, draw, design, transition, animation, then slideshow. At top, you can see home, then insert, then draw, then design. उसके आगे में है slideshow.
Yeah. Slideshow is here. Yeah. After animations. Top brown strip.
I think I'm using Zoom after a long time.
No problem. After, you clicked on review, then record, then slideshow. Slideshow. ऊपर मैम थोड़ा और ऊपर जहाँ होम है ना, होम, इंसर्ट, ड्रॉ, डिजाइन, ट्रांजिशन, एनिमेशन, स्लाइड शो. हाँ, जस्ट
there. You touch animation. After that, slideshow.
और मैम थोड़ा सा कर्सर ऊपर ले जाइए, थोड़ा सा कर्सर ऊपर ले जाइए. यस, और थोड़ा ऊपर जहाँ लिखा है. हाँ, अब थोड़ा सा लेफ्ट आ जाइए.
रिव्यू के बाद रिकॉर्ड, उसके बाद स्लाइड शो. हाँ,
उसके बाद उसके लेफ्ट में स्लाइड शो.
आफ्टर दैट देयर इज स्लाइड शो.
मैम
रिकॉर्ड इज स्लाइड शो.
रिकॉर्ड मैम कर्सर ऊपर, यस, थोड़ा और ऊपर, देन राइट, थोड़ा और ऊपर, देन राइट.
एनिमेशन के बाद स्लाइड शो.
मुझे तो एनिमेशन में नहीं दिख रहा मैम.
अच्छा, वो जूम का वो आ रहा होगा. मैम आप नीचे आ जाइए सबसे बॉटम में.
वहां तो कर सकते हैं.
जूम है ना, और थोड़ा लेफ्ट. हाँ, उसका नेक्स्ट टू नेक्स्ट.
हाँ, अभी कर दे.
यस, क्लिक ऑन.
ओके, फाइन.
ओके.
Is it okay, ma'am?
Yes.
Yes, ma'am, it's visible.
So what I really plan to do right now for the next 15 to 20 minutes is just to enumerate a bit about the mental health concept, which my earlier panelists, esteemed panelists have already spoken, and talk about gender socialization. And I want to talk about gender and mental health from a psychological, sociological perspective, keeping in mind the entire lifespan of an individual. And I also want to share data from a World Mental Health Report, National Mental Health Survey of India. And I want to conclude by talking about right-based strategies towards promotion of mental health and prevention of mental illness. Now, when we talk about mental health, according to the World WHO Mental Health Report 2022, it talks about the ability of a person to realize one's own ability, to learn well, and to work well. Earlier, there was a lot of thrust on being productive in the 2014 definition, but realizing the debates which are taking place, now the latest definition talks about working well and looks at the very fact that nobody has a life which is 100% perfect, and everybody has day-to-day stressors and day-to-day challenges to meet. So when we talk about mental health is how I feel about myself on a day-to-day basis, how I'm able to catch up with the demands of my personal and my professional life, how I in general feel about myself, how confident I am, the level of my self-esteem, and how I am able to form relationships in my life and deal with the challenges and try to reach my potentials to fullest extent possible. Now, Professor Wig said, which I really like, he gave this quote that mental health is too important to be limited to mental health professionals. The very fact that we are a very diverse group right now, there are students, there are mental health professionals, there are academics, there are practitioners from different walks of life, from wide disciplines, very, very well shows that we as human beings are interested in understanding our mental health better, and we should not leave the issue of mental health only to psychiatrists or psychologists or to social workers. Now we draw the connection with respect to gender and mental health. Gender, we know, is a socio-cultural definition given to boys and girls and men and women. And while nature makes us masculine or feminine, now it is society which makes us, if I'm a woman, I should look beautiful, I should be caring, I should be nurturing, I should be sensitive, I should be quiet, I should be dependent. Whereas if I'm a man, I should be aggressive, I should be strong, I should be dominating, I should be independent. So when we see the entire gendered socialization, we see that it is men who are having control over more resources, and there is denial of equality, there is injustice when it comes to food, when it comes to child rearing, when it comes to health, when it comes to political participation, recreation, and overall all the structures of society that we have. Now, I also want to add a disclaimer here that as a social worker, when I say gender, I do not mean only men and women. I also mean persons with alternate sexualities. Now, when we look at gender and mental health from a biological or psychological or social perspective, now, when we talk about it from a biomedical model, the doctors, the psychiatrists mainly focus on the genes and the neurotransmitters and the hormones, whereas when we talk about from the psychological perspective, we include childhood abuse, trauma, violence, parenting styles, death of somebody in the family, caregiving for somebody, trauma as an adult that we might face, and long-term conditions. From a sociological perspective, homelessness, living conditions, unemployment, death, gender discrimination, social exclusion on the basis of caste, class, gender, ethnicity, community-related issues, for example, poverty, deviance, drug abuse, alcoholism, all are very, very important. So when we talk about lifespan perspective, in the childhood, we know that we see conduct disorders, mood disorders. ADHD is one of the things which has really caught attention in the last 5 to 7 years. Intellectual disability, behavioral maladjustments among children. These are common mental health concerns when we look at the childhood lifespan stage. Now, when you further analyze from a gender perspective, we know that there is gender socialization by the family. There is son preference, female feticide, female infanticide. There is discrimination at school, because school also, as an agent of socialization, is also promoting gender in overt as well as covert ways. And of course, there is child abuse, incest, and so on. When we talk about the adolescent stage of lifespan, now we know that the onset of menarche puts socio-cultural restrictions on the girls. And suddenly, because of the overhype by media, today we also see that there are concerns and pressures on girls as well as boys to look slim or macho respectively. The careers are also linked with gender. Girls are told to maybe take up academics, maybe nursing, whereas the boys are told and encouraged to take up certain other occupations and professions. So mental health issues among adolescents are anxiety, eating disorders, depression, onset of substance abuse, alcoholism, suicide. Now, when we look at the adulthood stage, now there is anxiety again, post and peripartum depression, sexual dysfunction, alcohol and substance abuse, PTSD. And when you look at it from a gender perspective, choice of partner, do I have a right to choose my partner? Do I have a right to decide when I want to get pregnant? What about the pressure on me as a woman, for example, to bear a male child? Work-life balance, violence, single parenthood, divorce, sexuality, career choices, access to resources, sexual harassment at workplace are some of the gendered concerns when we talk about the adulthood lifespan stage, which in itself is very, very vast and wide. Now, when we look at the old age, now we are looking at neurocognitive disorders, we are looking at depression among elderly, and there is, from a gender perspective, neglect and abuse, widowhood, and there is reduced social support. Now, the WHO has talked about certain risk factors which actually intensify a person's vulnerability to actually get a mental disorder. So when we look at the risk factors, these can be sexual and physical abuse during childhood, family and social community, school violence, poverty, social exclusion, so on and so forth. Now, when we look at gender and mental health together, now, it has to be looked at from a very eclectic perspective. It has to be looked at from an intersectional perspective. Now, because women are a part of the larger society, and larger society is patriarchal in nature. So therefore, the social realities of women, the cultural context of women, that has to be taken care of when we talk about gender and mental health. Now, coming to the data from the World Mental Health Report 2022, now it strongly talks about the risk factors. It says that, as you can see in this graph, now when the individual vulnerability is low, it means that there is going to be a lower risk of mental health conditions. Whereas if I have a higher susceptibility, higher vulnerability, then I am going to be at a higher risk to develop mental health conditions. So when we look at it from the individual perspective, from a gender perspective, now genetics, low education, alcohol and drug use, unhealthy diet, obesity, chronic disease, vitamin D deficiency, body dissatisfaction, sleep disturbances, obstetrics, complications at birth, these are very, very important individual factors which make women much more prone to develop mental health conditions as compared to men. Because the entire incidence of violence across the lifespan, different types of violence, stigma, discrimination, poverty, gender socialization, all these make women much more vulnerable to developing mental health conditions. I'm not using disorders word, I'm using conditions as compared to men. Now, the latest report, National Family Health Survey 5, it says that 23.3 girls under the age of 18 are married. Only 1.9% women have been screened for cervical cancer. 0.9% women have been screened for breast cancer. This talks about how much importance is given to women and her health. And we know in the order of priority, mental health is something which is going to be at the bottom. MMR is still very high, though the rates are improving, but still it is very high. Literacy rate is still, as compared to men, lower. So therefore, individually, women are much more prone, because of the larger socio-cultural context, to develop different mental health conditions. They are more at risk. In terms of family and community factors, sexual abuse, violence, job strain, intimate partner violence, urban living, which increases stress in the life of a woman, all these are also important factors. In addition to that, there are some broader structural factors according to WHO, which also put women at much more risk as compared to women. Climate crisis, poor services, gender inequality, conflict and forced displacement. We know what is happening in Manipur since almost a year. So who is more affected? Is it men more? Is it men or is it women? These are some of the things which we need to think and ponder over. Now, so when we again, now World Mental Health Report has clearly said that it is women who are more socioeconomically disadvantaged as compared to men, and they are more exposed to intimate partner violence and sexual violence, and that is why they are much more prone and at risk. Now, out of the 970 million people who were having mental disorders, this is before Corona, now more than half were women. It is seen that anxiety and depression is more common in women as compared to men. Now, when we talk about the home front, the National Mental Health Survey, NIMHANS, the report came in 2016. That also clearly says that the depression and anxiety, these are more common among women as compared to men. Now, when we talk about challenges of treatment, if I have a disorder, now I also will go and try to seek treatment if at all. Now, number one, my mental health as a woman is not a top priority for anybody, including me. Therefore, there is very little treatment available because there is lack of support. Who will take me, for example, to the doctor or to any private practitioner or to a government hospital regularly? Because these treatments require much more cost and, of course, much more time. There is also stigma in case of women affected by mental illness. Now, Tata Institute of Social Sciences conducted a study where they said that Marathi, Vibhuti ma'am will correct me if I speak anything wrong, but they said, "Amchi mar gayi to ye tumhari hai." They left the women to in the mental asylums. "Mar gayi to tumhari hai, theek ho gayi to hum isko wapas le lenge." So they throw and shun the women and at the doorstep of the institutional care. And they said that if she dies, she's yours, and if she is somehow treated and recovers, then she is mine. Women are also, if they have mental
But in
illness,
reality, people don't come. And that's why TIIS has also had to start a project where these women could become self-dependent. Because families, even after they are mentally okay, families are not ready to take them back.
Absolutely, ma'am. Absolutely. Because they are banished from their conjugal home and they are sent to their natal home because nobody wants to deal with a woman who has some kind of a mental disorder. And there is a lot of difficulty in rehabilitation. Now, mental disorders and the intensity and the frequency is also emphasized by latest international reports, where the very fact that people are more lonely, people are actually not having social connections, and there is declining social self, especially among the young generations, and the friendships are also deteriorating because friends are digital friends. So therefore, risk of mental health challenges is 10 times more as among those people who lack close family relationships as compared to those who have some kind of friendship. Now, WHO in 2013 November, it is now recognizing loneliness as a pressing health concern, and it has to be a global priority, and therefore a commission on social connection has been set up in November 23. Now, looking ahead, Now, I think there is, we have evidence when we talk about gender and mental health and how women are suffering more. However, more research is required, and lifespan perspective also has to be taken care of. And on the individual front, or the family and community front, structural front, all these things are also very, very important to be kept in mind. And we need to promote the protective factors, whether it is secure attachment, whether it is in our child rearing practices, teaching children to talk about mental health, and it's okay to feel low, it's okay to feel depressed, and trying to teach them life skill, trying to teach them coping skills, positive self-regard, no matter whatever pluses and minuses, strengths and weaknesses I might have. These things are very, very important. And we have to talk about early identification of signs and symptoms, having school-based programs, community mental health programs, involving social media, non-governmental organizations. And we have to promote a culture of self-care. With that, I'm going to stop, and thank you.
Thank you so much, ma'am, for sharing your insights with us. I would now like to call Professor Vibhuti Patel to give the chair's remarks. Ma'am, you're muted.
For summarizing so many important reports currently by WHO, as well as the current concerns that we have in a post-pandemic period. In fact, your book is an extremely important resource for all those who are working in the area of mental health, and also the gendered analysis that you have provided in that book, Gender and Mental Health, recently published. Only thing, it should be accessible to the community-based workers and the citizens of the country, because there's such a valuable insights are there from psychiatrists, psychologists, social workers, community-based workers, feminists and women's rights activists. So I think that should be made. I don't know how can we do that, but I think maybe after 2-3 years, Springer will make it and put it in a public domain. They do sometimes. So I think but we should negotiate for that. Yeah, deprivatization of knowledge. It's important. Yeah.
Thank you so much, ma'am. I would now open the floor to questions. Chitra IRG, would you like to ask your question? I can read out the question. So
there are 10 questions already in the chat box for the 2 of them after Dr. Aparna started speaking. Yes.
Yes. So she asked, women do not have the decision-making power on where to get access services, public or private, and also on whether to access service. Given this fact, what should we as practitioners do? Dr. Aparna Joshi, ma'am, I think she asked the question during your
question to me. Yeah, I'm reading the question also.
Yeah.
Yeah, women do not have the decision-making power on where to access public or private, and also on whether to access. Given this fact, what should we do as practitioners? So I think over a period of time, as I have also changed my approach in terms of service provision. In community mental health, we say that clinical models are more operating within a waiting mode, whereby they wait people to come to you and then, you provide services. In community mental health mode, you actually activate a seeking mode, whereby you go to communities in some or the other forms and start providing services which make sense to the community. I think there was a question also asked to Dr. Manjula about a lack of knowledge. People are not aware. I think that lack of knowledge exists in urban geographies also and rural. But people's explanatory models of why they have distress are very different from the Western medical models of what they think is wrong with people. So I think service providers need to go to the communities, need to listen to what people actually need. Do they need medication? They need cognitive behavior therapy? Or do they need perhaps self-help groups, maybe economic empowerment programs? That's why I said that mental health is a development issue. And sometimes development is a good channel to reach women, to start services. And some of your traditional medical mental health services may not be a good model. This is something that I have realized over a period of time. Sometimes just holding community meetings, sometimes just having some groups of women, talk to each other, explore those spaces within. That could be a good starting point, is what I would say. It's not a panacea to all the questions, but that's a good beginning for sure.
Thank you, ma'am. Malaji, would you like to ask your question?
Yes, I'd like हिंदी में बोल सकते हैं?
हाँ,
जी।
आप बोल
तो
सकते
अभी जैसे डॉक्टर अपर्णा ने बताया ना कि सर्विस प्रोवाइडर को जाना चाहिए, तो मैं ये समझना चाह रही हूँ कि हम कैसे ले जाएं। हम भी एक एनजीओ के साथ काम करते हैं और हम स्लम डेवलपर्स में काम करते हैं, जहाँ पे ये सब्जेक्ट ना उनको समझ में ही नहीं कि वो लोग इफेक्ट है इस सब्जेक्ट से। तो ये अगर हम बोले कि भाई आपको मेंटल इशू है, तो वो कहेंगे नहीं आप हमें पागल बोल रहे हो, वो एक एक्सट्रीम लेवल में फिर चले जाते हैं। तो फिर हम कैसे उनके साथ ये सब्जेक्ट शुरू करें और कैसे सर्विस प्रोवाइडर को वहां तक ले जाए, क्योंकि यहाँ पे अगर सर्विस प्रोवाइडर को ले जाना है तो थोड़ा इकोनॉमिक भी हमें देखना पड़ता है। तो उस पे कुछ बात हो तो सुनना चाहेंगे हम इस पर।
और मैं जल्दी से कुछ आंसर दे के निपटा नहीं चाहती हूँ बात। शायद आपको अगर और खुल के बातचीत करनी है तो बाद में भी हम बात कर सकते हैं। पर एक बड़ा सा मुद्दा है कि मानसिक स्वास्थ्य की बात जब हम कम्युनिटी में लेकर जाते हैं तो क्या शब्द भी इस्तेमाल करते हैं। मानसिक स्वास्थ्य, ये शब्द आप इस्तेमाल करोगे तो कम्युनिटी आपको वहां से एक्सेप्ट ही नहीं करेगी। बट कम्युनिटी के अपने इडियम्स ऑफ डिस्ट्रेस होते हैं, उसको इडियम्स ऑफ डिस्ट्रेस, वो महाराष्ट्र में उसको लोड बोलते हैं, स्ट्रेस बोलते हैं, टेंशन बोलते हैं, घबराहट बोलते हैं। अपनी अपनी कम्युनिटी की एक लैंग्वेज है, उनको कहाँ पर डिस्ट्रेस है उसकी उनकी एक परिभाषा है, शायद वो जानना जरूरी है। और आपकी संस्था के जो वर्कर्स है उनको भी ट्रेन करना थोड़ा जरूरी है कि कैसे हम साइंस ढूंढे कि कौन व्यक्ति है शायद जिनको ज्यादा देखभाल की जरूरत है, कौन व्यक्ति है जिनको ज्यादा सपोर्ट की जरूरत है, शायद मेंटल हेल्थ थेरेपी की जरूरत नहीं है। पर वो जानना और उनकी भाषा में उनको कनेक्ट करना। और बहुत सारे वेस्टर्न मेंटल हेल्थ मॉडल्स ना इंडिविजुअल बेस्ड है, एक एक व्यक्ति को आप प्रोवाइड करो सर्विसेज। पर इस कम्युनिटी में शायद ग्रुप में बात करोगे तो शायद, और तनाव के मुद्दे पर भी बातचीत छेड़ना जरूरी नहीं है, शायद कोई और मुद्दा हो कि फैमिली में होने वाली चीजें, बच्चों की परेशानियां या कुछ स्किल बिल्डिंग के साथ अगर आप इस मुद्दे से बातचीत करना शुरू करें और धीरे धीरे आपके स्ट्रेसर्स क्या है उस पर हम क्या बातचीत कर सकते हैं, दैट इज ऑलवेज अ बेटर अप्रोच। पर ये छोटा सा ही संक्षिप्त उत्तर है। अगर इसका, क्योंकि हम आईकॉल के माध्यम से भी काफी सारी संस्थाओं के साथ ये काम कर रहे हैं कि आपके काम में मेंटल हेल्थ को आप कैसे जोड़ दे, क्योंकि मेंटल हेल्थ स्पेशलिस्ट एनजीओ की भाषा नहीं बोल सकते हैं, आप ही कम्युनिटी की भाषा बोल सकते हैं। आपका जुड़ाव अच्छा है, आपकी क्रेडिबिलिटी अच्छी है, आपकी समझ, उनकी नस पकड़ने की जो आपकी क्षमता है वो अच्छी है। तो उसमें अगर आप मानसिक स्वास्थ्य का मुद्दा जोड़े, कम्युनिटी आपको ज्यादा एक्सेप्ट करेंगी। विस्तार से बातचीत करने के लिए मेरी जरूर चाहती हूँ, पर अभी इतना ही संक्षिप्त में जवाब देती हूँ। और मीनू जी, डॉक्टर मीनू, इफ यू वांट टू ऐड समथिंग।
नहीं,
और
मैं
आपने
आपकी
अपना
बातों से
मोबाइल नंबर भी
सहमत
शेयर
हूँ।
किया है, तो ये भी है।
मैं अपर्णा जी की बातों से पूरी तरह से सहमत हूँ। मुझे भी ऐसा लगता है कि हमारे को नॉर्मलाइज करना होगा मेंटल हेल्थ की बातचीत में, चाहे हम स्कूल की बात करें चाहे हम कम्युनिटी की बात करें। तो हमें समुदाय में भी एक ऐसा एक माहौल क्रिएट करना है जहां पर हम दिल से जो भी हम महसूस कर रहे हैं उस बारे में हम बातचीत करके एक एक जिसे हम कहते हैं कि हम हल्का फील करते हैं। तो आई थिंक शुरुआत हम वो उन मुद्दों से करें, चाहे हम मिलकर गाना गाएं, चाहे हम मिलकर जो है हंसे, हम बात करें एक दूसरे से, एक दूसरे के दिल की। आई थिंक शुरुआत हमें वहां से करनी है और फिर धीरे धीरे जैसे अपर्णा जी ने बोला फिर उन मुद्दों पे आना है जो हमें शायद कहीं खटक रहे हैं।
बराबर।
शुक्रिया।
Ma'am, can I go ahead?
Yes, ma'am, please.
Yes, so drawing from our previous participant, Mala ma'am, this question is for Aparna ma'am. So ma'am, you just mentioned that most women suffer from distress more than mental health illness as such. And you just used some terms like load, stress, uh, basically the language that women, or in general, a certain kind of regional based population use to understand mental health related issues. So my question to you is that, as you have mentioned, that most women have a tendency to suffer from distress and they do avail community services. So what kind of symptoms, because there is a strong sense of internalization of social values that happen to women. For example, because of stigma, women will not come out with their mental health problems. So in a situation like this, what kind of symptoms do they identify as symptoms of distress and go ahead to take these kind of to take community services? So what are these symptoms? If you could just help me identify that.
Sure, sure. When I was referring to Bhargavi Davar's language of distress rather than illness, she was referring to common mental disorders such as depression, anxiety, rather than severe mental illnesses such as schizophrenia and bipolar affective disorder. So just wanted to clarify that. But women, what kind of symptoms do women bring? If you look at research from South Asia particularly, people, unlike global north, do not present their distress necessarily through emotional or cognitive symptoms, but through body-based symptoms, right? So a lot of times, people who go to PHCs, CHCs, general practitioners, family physicians, there is data to show sometimes 15 to 40% of those people are actually suffering from distress or common mental disorders such as depression, anxiety. So they will talk about headaches. Women particularly talk about very unexplained physical symptoms, right? Also, in a country like India, if women start saying, I'm depressed because I suffer from domestic violence, ना आप डिप्रेशन के बारे में बात कर सकते हैं, nor are you allowed to talk about domestic violence because of family honor, possible consequences. But they may talk that my body aches, my headache, many other. So that's a language, for example, women will talk about definitely, number one, and it's a good language to identify. Women also understand the language of stress. Women also understand the language of emotions. They will say sad, they will say perhaps anxiety, घबराहट होती है. So I think we need to listen closely. And when it comes to men, for example, men may express their mental health problems again more through different kind of a language, aggression, and we may see aggression as possible symptom of depression also. So very important to understand those things. So maybe this is a good way to talk to women. And second thing I want to say, as mental health professionals, we need to work on two levels, but we continue to work only on one level. One is we identify distress and we try to look at that distress through some symptom reduction, largely biomedical treatment. But distress in women's life is caused because of multiple factors at home, public places, private places, workplaces. Women don't require just help in getting rid of the headache and getting rid of anxiety, but also getting rid of violence, getting rid of discrimination, getting good employment. So I think organizations need to deal with mental health through distress reduction, but also through actually targeting stressors and overall empowerment of women. Otherwise, we are just creating some very superficial solutions without actually handling the real life issues. And that's a bigger task. I'm not saying it's an easier task at all. Easier task is to provide symptomatic treatment, but I think we need to widen our understanding of mental health and start. And if you can't provide services, at least have a good referral list. At least have good referral linkages. At least have a good intersectoral dialogue. Right? Have you created a list of all organizations that work in your area? Maybe that's a good beginning, so that at least they will be referred to relevant people. That's my immediate answer. Thank
Hi,
you.
can I speak, Rahman?
Yes. Yes, ma'am.
Yeah. Hi, this is my question for Dr. Aparna. Thank you, madam, for your session. So so to give you a little bit of a background, I used to work with the Women Development and Child Welfare Department of Telangana State, where I was coordinating the Sakhi One Stop Center helpline, the project. I observed that, a lot of times in these one-stop centers, mental health is an alien concept still. It is more of a conciliation model rather than a mental health support model. And linking it with the Bolsa Familia study in Brazil, which says that economic empowerment kind of significantly reduces mental health issues and also a reduction in suicides. is there any provision, a legal provision in India to facilitate such kind of economic empowerment in women? Because I see that, even Mental Health Care Act doesn't really focus so much on social or economic empowerment. It is more of, again, a biomedical support system with respect to the act. So I just wanted to understand, where are we breaking ground with respect to this in India, where we are focusing more on social and economic support, because there are studies indicating very clearly that, economic empowerment is directly linked to reduction of mental health issues. So I request you to please elaborate on this, and also, any pointers that we can use in our work as well, Thank you.
I would like to add one more thing to Dr. Aparna and Meenu Madam also, that in the gender budgeting, which is done from 2021, 740 crores, this year also there's a massive, is there a provision for economic self-sufficiency of a woman who faces, looking at the stigma she faces from family, from the in-laws, from the community? Because whenever it comes to, say, sexually abused survivor, we talk about the rehabilitation, and Manodharya scheme is there. So have the psychologists and psychiatrists put forward this demand so that whatever money is allocated is not only for counseling, but also for a complete rehabilitation, not only psychological, but economic also.
So I think, Vibhuti, you are the best person to answer the economic, empowerment. I think you are the scholar in that area. But I'll just definitely respond to your question basis the one-stop centers that operate. I have been working with one-stop centers, and with UNFPA, I actually came up with a 15-session program to which also integrates mental health into capacity enhancement of one-stop crisis. Now they are called one-stop centers. It is an alien concept, mental health. I completely agree with you. So economic empowerment is very, very important, and there are contradictory studies from India. Some studies show that it decreases violence, some studies show it increases violence, but overall conclusion is that it actually reduces violence and it empowers women. So it is very, very important. I think the idea of one-stop centers is not about, although majority of them are supposed to be based within the health system, is actually intersectoral linkages to address mental health violence against women in a comprehensive manner. But the way it is run currently, it is run either under the ambit of health system or women and child welfare department, but they are not coordinating with perhaps social justice ministry, perhaps other economic empowerment schemes also. So I think there is it's very important, because seriously, women, if you just give them mental health solution, will not be interested if you don't give them other solutions which help them feel more empowered in their everyday lives. When I started working with issues of violence against women, at one point I felt I want to give up my counseling work and only do economic empowerment and employment bureau. Right. So over a period of time, I realized that I can't do everything. Maybe I need to have good tie-ups with organizations that work on perhaps skill building, that work on perhaps, self-help groups, or that work on microcredits, that work on, or I need to collaborate better with government departments where all of this work is happening. And I need to be that advocate actually to facilitate, bring all of them on one platform. It's not an immediate solution, but I started getting up as a counselor and literally talking to women's organizations saying that, hey, I have a group of survivors. Can you come and do skill building for them in my premises, organizations? Can I send 3 of them for English speaking classes? Can I send 2 people to your organization as part of your NGO? It's a very difficult, policy level work is also required, but individual women level work is required.
Yeah, but the reconstruction of budget on mental health,
I agree
with the major head, minor head schemes, programs, and the allocation, which you people can suggest in terms of funds, functions, functionaries.
Agree. I agree with you, but Vibhuti, you can also add in terms of whether there is money for women's economic empowerment, and whether are those departments talking to one-stop centers also. To my mind, unfortunately, there isn't much of a dialogue. And those victim compensation schemes also, Vibhuti, I don't know how many people can actually, how many counselors in one-stop centers know about Mano Adhairya scheme? How many of them know
But
about
at
other
least in principle, it is accepted, no? There is a budget,
agree.
there is
But I
money
will
is
tell
parked
you-
in the ministry. It may not be
Agree.
fully utilized, but at
Agree.
least that starting has started. That has started, no? Yeah.
And if you look at the Rights of Persons with Disabilities Act 2016, there are 21 disabilities. One of those disabilities is acid attack survivors, right? So if you start accessing that, you have multiple benefits under that for acid attack survivors. So which means employment, reservations in education, income tax exemption, some small credits for starting business. I think we need to find
similar
multiple these schemes which can dialogue. And I've struggled. I mean, I don't have an answer, but people who are at a policy level as well as a practitioner level need to advocate for that larger change. Without that, it's not going to.
Yeah, so some centrally sponsored scheme as well as the subnational level capacity building of the actual budget makers. In that, we can do the listing of all these services, no? Should be, including economic empowerment.
Thank you, ma'am. Rashmi ji, would you like to ask your question? I could read it out live.
Mr. Ramiz Ahmed has raised.
Yes.
He has raised his.
Yes, I'm
Yeah.
an educator and teacher educator from Jammu and Kashmir, and I happen to be one of the fellows from India who was on my Fulbright fellowship to US recently. And the core area which I was really very interested and keen to understand was the social emotional learning of the children in US, in Massachusetts. And before that, in fact, I have been associated as a teacher educator into the social emotional and mental social emotional well-being of children. But I just want to know that it at times, and being coming from a place like Kashmir, the context you already know, so I feel compelled and I feel really the sense of urgency in me that I should extend this the SEL work, the kind of work I do with children and teachers into mental health. And safely so, saying so, is there any possibility that I can really upgrade and upskill my own self and then get kind of develop the kind of comfort level, and so that I can also talk about the mental health, which is the need of the hour in our society. And also coming back to SEL, how can I really further improve upon my skills and really enrich myself, and so that I will be better equipped, and through professional development courses or anything else you want to just give insights about. And and because mental health in our case is very significant and very important, because learning, I think, comes later. Mental health and the social emotional learning of children is of great significance in our case. Thank you so much.
Yeah. Do I answer that question? Is that okay if I answer that question? Yeah. Dr. Meenu, you want to go ahead?
Please.
Yeah. No, I have 2-3 answers to that. One is there are some good organizations. Again, I mean, please feel free to write to me that offer training in for trainers or practitioners in socio-emotional learning programs. How do you execute those programs within community, school, or other institutes also? So I'll be happy to share some of those resources also. I also want to talk about 2 programs that the government of India has been running. The Rashtriya Kishore Swasthya Karyakram, which has been running in India since 2014, and the school health program, which has been launched under the Ayushman Bharat scheme since 2018. Since you said Jammu Kashmir, and congratulations on your Fulbright fellowship also, I think you are in a very key position as far as that state is concerned in terms of integrating socio-emotional learning within state-run facilities, right? Because sometimes I am a great believer of the fact that instead of working in isolation, work with the government, because the kind of reach that the government has, nobody else has, but have your own dissent and critical engagement with the government also. So I feel that these 2 programs are a fantastic opportunity for you to talk to. So it is run by Health Ministry and Ministry of Education, right? And it's a good idea to talk to the concerned people and just talk to them. How many districts, for example, how many schools are being covered under RKSK and under the school health program? And can you integrate socio-emotional learning programs? there is fantastic evidence from India which shows that socio-emotional, and it's a preventive level program. Government doesn't have resources to do curative work. So if you are interested in preventive level work, literally there is no money. So if you can actually provide some kind of an assistance over there, the money is supposed to be there, templates are there. If you go to the health ministry's website, there are two manuals. One is the RKSK manual. It's a good resource to look at. And the second manual is primarily the school health program manual. And it talks about some of the socio-emotional learning agendas also. I call also, if you go to our website, we also have come up with some kind of counseling protocols also for working with adolescents and children. So I think these resources I'll be happy to share. Some of those are shared by the ministry themselves. And the training courses, I can definitely come back to you. But I think you are in a very unique position to sort of, influence this.
Thank you, ma'am. I'll read out the next question. So, Snehal Rathorji had asked, has gender budgeting been helpful to address inequality related to mental health stressors?
I think Professor Patel is the right person to answer this.
I think first of all, for the first time, Government of India in the union budget gave allocated money after so many reports were about the intensification of violence, domestic violence that happened, so much of mental distress that was found, so many childline helplines where they had received more than 2,75,000 calls. In response to that, this money was allocated, but now how to use it creatively and concretely, that is important. Otherwise, what will happen? I asked last time, proposals are mostly going from Kerala. Why other states are not sending proposal? NIMHAS is the nodal agency which has to screen the proposals and give funds for various services and schemes. So I think awareness about this, that there is a fund, there is an allocation of budget and we need to use it. So I think it is now the ball is in the court of social workers and community-based workers and mental health professionals, that how to use it either for capacity building or for counseling or for running the self-help groups or the shelter homes for women, because everywhere there are not mental hospital. So community-based counseling services, or a creation of drop-in centers, which during the 80s women's movement had created. Saheli had a drop-in center, Women's Center had a drop-in center, where you just come up with the support system. So all these things, we need to create this kind of services. Then only money will be utilized. Otherwise, the same thing will happen that happened to Nirbhaya Fund. Nirbhaya Fund from 2013, we have 1,000 crore per year. Hardly it is utilized. There are 5-6 states who are sending proposals, that to 40 to 50% utilization. Most of the states and union territories, I have 100% non-utilization. When I was in Gujarat, I went to Gender Resource Center and we were talking about Swadhar Grah. The principal secretary of Gujarat, he said that if we start Swadhar Grah, Gujarati women will start running away. So if this is the mindset of the bureaucrats and IS officers who have a power, and if they talk about in the planning department or in the finance ministry, they think like that, then even when the money is there, it won't be utilized. So how to build the pressure, how to do public education on budgetary allocations. And so, and 2-3 years, if money is not utilized, they will curtail the budget. It will become from 740 to 300 crore. And after that, it will become 100 crore. And after that, they say, no, these services are not required. Let us scrap it. We can use it for some other program. No?
Thank you, ma'am.
Yeah.
There was somebody who said about having bipolar disorder and if she could continue IAS. So I'm sorry, I don't remember the name of the person, but I want to just, by chance, I happen to have this book on my desk. Can you see this book?
No, ma'am, it isn't visible.
I'm showing this book.
Bring it
Now
more.
it is visible.
Little up.
Yes, ma'am.
Yeah.
This book is Barriers to Recovery from Psychosis, and the author is Pratiksha Sharma. Pratiksha Sharma is a survivor of bipolar disorder. She had bipolar for 18 to 19 years of her life, and she has come up with this book last year where she's talking about what are the challenges of recovering from psychosis. and she draws upon her own experiential reflections, and she's done her PhD after her recovery, and she is writing a lot, and she's a survivor of severe mental disorder. So you can refer to this book, and if you Google online, there are some articles written by her which are available free to download.
Thank you,
I
ma'am.
have a question for Dr. Aparna. Madam, thank you for that insightful talk. I'm Dr. Anavisha Banerjee from University of Delhi. I just want to know, is the traditional way of healing more time-taking than the medicinal one? Or even if it is, it's more effective, or how do you see it, or it varies?
So I think first of all, we need to be clear about what is traditional healing also. It is different from Ayurveda, homeopathy, or what we call as Ayush. That is not traditional healing. Traditional healing is basically, traditional healer is that person who is supposed to have a relationship with the metaphysical and is entrusted with some kind of powers, healing powers, and he's a medium between that metaphysical power and the service delivery. He himself is not God, right? Or they or she, whatever is the gender of that person, right? So in India, we have traditional healers, or we have traditional healing sites. Sometimes some temples or dargahs, or perhaps some other religious sites are also supposed to have these properties of healing. So I think very important to have that definition. Traditional healing has been now researched very well in the world also, and in India also. And whether it can heal or not, what kind of illnesses it heals. Typically, research shows that common mental disorders, which are more depression, anxiety, somatoform disorder, dissociative disorder, जिसको हम possession syndrome भी बोलते हैं कि किसी के अंदर देवी आ गई कुछ. So most of those disorders are much better treated by traditional healers. In fact, if you are interested, there's a very, very well documented project called Dawa Dua in Gujarat, right? And impressive results. Nimhans has also done this study with Balaji Temple in Tamil Nadu. Impressive results to show that even psychosis can get cured. So very important. I used to work with an organization based in Pune called Bapu Trust. They have also published tremendous literature to show how traditional healing in Maharashtra is actually contributing to better mental health. Having said that, we need perhaps to understand what is it about traditional healing that is actually healing, and what is it about psychiatry that is sometimes not healing. Traditional healing is very close to people's understanding of why do I have distress, right? They don't think that because I have a chemical problem, I have problem. They understand whatever religious, spiritual models. So that's why it's very close. Also, there is no confidentiality. The whole community is participating. There is no stigma. It's very close to my home. Women, you see, are women allowed to dance in streets? But in temples, women will be allowed, their saris will be flying. So a lot of acceptance of self is there. And that's why it's healing, but particularly more so common mental disorders as compared to psychosis or bipolar affective disorder. Having said that, I don't want to glorify tradition. There are lots of problems of human rights also. In fact, Erwadi is a very, very important incident that happened in Tamil Nadu's Badusa district. And Supreme Court actually came up with a directive saying, shut down all traditional healing centers in India. Today, we are in a much better space to say that don't shut down, don't have drastic. Let's have partnership, right? The modern medicine and the traditional healing discourses can dialogue with each other. And Davadua is a fantastic, BBC has made a film also on it. It's a fantastic model. So if you remove the human rights violations and gender rights violations also, or some of the unhealthy practices also, sexualized practices also, I think it's a great resource for South Asian countries. It is always treated either as a suspicious superstition, or it is treated with a lot of exotic values where Julia Roberts explores it in Eat, Pray, Love, right? But it requires its due credence where it is a resource and sometimes the only resource which is available to the communities. So let's not dismiss it. It's a fantastic resource. Let's collaborate and do something. And there is plenty of research. If you are interested, I'm happy to share some of the readings also with you from India itself. I hope I've answered your
Yes,
question.
thank you, ma'am. Thank you so much.
Thank you, ma'am. We have the last question. Are there any studies or readings that will be recommended which might throw insights on the interplay between religion, caste, social customs or traditions, and mental health among women?
There are a lot of reading materials, and I think everybody at the end of the winter school will be getting some of the resources that have been shared by the resource persons.
We have already shared them with
Okay.
everybody, all participants.
Okay, okay. And we can always add more, right, ma'am?
Yeah. Yes. We can
Based
add
on
more.
the questions.
Yeah. And even in the all those resources in the, if you see the reference list of references at the end of the article or document, there also all the resources are there. Yeah. It has been shared.
Thank you so much, ma'am. Thank you so much, Dr. Aparna Joshi, ma'am. Thank you so much, Dr. Meenu.
There is one more question. Can you please share any reference link on school-based program for mental health?
I think the NCRT survey, sorry.
Yeah. No, go ahead. Please, go ahead.
No,
Yeah,
I was
exactly.
saying that one can, to start with, one can go through the NCRT mental health survey, which was done 1.5 years back. So that is, I think, a good starting point. And in that also, you will get lots of references and lots of reading material that you can explore further.
Just share the link if you have. Otherwise, title of the study. Yeah.
And refer to the Government of India Ministry's website also. All the manuals on school health programs, RKSK, every material is there. And there are plenty of studies now which have already evaluated RKSK. I was a part of a national level study where we evaluated RKSK in 3 districts. And there are lots of studies which are coming up which are evaluating even school-based programs. But if you need some training, I'll be happy to share some resources.
Thank you so much, ma'am. Thank you, ma'am. It was a delight to have both of you with us today, and thank you for sharing your expertise with the participants. We look forward to seeing you at future IMPRI sessions as well. We would now move on to the participants' introductions. So participants can introduce themselves.
If we can exit, I mean, if I exit, is that okay?
Yeah.
But thank you so much for inviting us, and thank you so much to all the participants for such a brilliant discussion and such insightful questions. And I sensed a level of passion in every question. So best wishes to each person's journey, and hope you continue to make difference, and more power to your journeys also. Thank you.
And I think let's always remember that mental health is our own unique journey. It's a positive journey. And we are always moving on the continuum, this side, that side, but we are moving.
We have shared email IDs of both the resource persons, so you can also communicate with them. Yeah. Dr. Aparna Joshi, Dr. Meenu Anand, their numbers.
Thank you so much, Professor Patel. Thank you so much.
Thank you. So participants are requested to provide their name, location, designation, organization, and why they chose to take up the course. And they can share any other comments that they may have. You can raise your hand or you can unmute now.
Yeah, hi.
Hi, sorry, please go ahead.
You can go ahead, please.
Okay, thank you. My name is Dr. Ojaswini Trivedi. I am currently working in an organization called Society for Women's Action and Training Initiative, Swati, and it's based in Ahmedabad, Gujarat. So we primarily work in gender-based violence and more so on the rural health sector response to violence. So we primarily work with training and capacity building of the doctors to be able to suspect cases of violence, and additionally with the Ashas in Patel district of Gujarat to be able to understand and suspect early signs. Well, the reason, and I'm program coordinator for the same, and the reason why I wanted to join and be a part of this is because I think when it comes to discussing violence or understanding violence among women and the kind of cases that come to us at the hospitals, there is always a big gap and a barrier to understand their mindset. Because most of the times we have seen cases where women come and they say ki, heart, they'll have fractured hands, or they'll have burn marks, or they'll have bite marks on their chest. And when our counselors would ask them, ki kya hua, ya aisa kya ho gaya tha, ya aap theek ho, their response would be very मैंने सास को चाय नहीं दी, या मैंने ऊंची आवाज में बात कर ली तो पति ने मार दिया, एंड उसका हक था. So all this awareness and all this for them to not even know that what is happening to them is wrong at so many levels. And I wanted to understand the mindset, like, what goes behind a person accepting violence as if they deserved it. So yeah, that is the reason why I wanted to become a part of this.
Thank you. Thank you for such a detailed discussion. Now, Yagna Parmar, please go
Hello. I'm Yagna and I'm from Vacha, Mumbai, and it's a very old organization. We have been working with adolescents and young women from 1996. My objective of joining this course is mainly because Vacha has a great presence in communities. We have been a grassroots organizations where we have a girls empowerment programs with in the Mumbai slums. So and we understand that mental health require a comprehensive model and integrated model. So our idea of what kind of specific interventions can be made with mental health on the issue of mental health with adolescents and young women. So just wanted to understand more strategies, practices, challenges which can come up, and of course to know more resources on that part. Thank you very much.
Thank you.
I'm Dr. Anavisha Banerjee. I'm from University of Delhi Bharati College English Department. My area of interest is gender studies, and I want to explore gender and mental health as one of its facets, which I can use through different literary works. Thank you so much.
Thank you. Renuji, would you like to go ahead?
Yeah, I'm Mrs. Renu, Assistant Professor at Royal College of Arts, Commerce and Science, belonging to a commerce background. In last few years, dealing with the identity crisis among the adolescents and the teenagers has become a real issue for the mentors like us in the college. College students, really, boys and girls, are facing identity crisis. And I, being from a commerce background, I wanted to meet you all to understand your experience perspective in handling the difficulties faced by the students. That was the main reason of joining this course. Thank you.
Thank you. Sushma ji, please go ahead.
Yes, can you hear me?
Yeah.
Yes.
Yeah, I'm Dr. Sushma Murthy from Christ University, Bangalore. I teach gender studies. I'm currently completing a major research project on a psychoanalytical writer in Kannada called Triveni, who was very futuristic in her understanding of mental health issues among women. She passed away somewhere during the 1960s, unfortunately, at a very young age. But then she has written 4 novels about different mental illness, issues that women faced because of psychocultural factors, and we discuss psychosocial, factors. And because I'm researching on it from a literary perspective, from a psychoanalytical perspective, I found it necessary also to touch base with practitioners and activists in the field who could throw more light on women's mental health. What I'm looking at is narratives of hysteria and other mental, conditions, and how literature can help us to be more sensitive to women's issues, because it is one of the most interdisciplinary approaches, I feel, a literary approach. And I'm trying to bridge the disciplinary gaps between, like what ma'am said, Dr. Aparna said, distress and the clinical condition. So a lot of these literary perspectives give us the distress perspective. And thank you so much for having me here. I'm really, benefiting a lot. Thank you.
Thank you. Caroline ji, please go ahead.
Good evening. My name is I'm Caroline, and I'm doing my PhD at Royal Holloway University of London. So, gender and development is one of my passionate area. Apart from this, I have also in my past work I have also associated with City of Kochi, basically Kochi Municipal Corporation, for implementing some mental health intervention. So, along with my PhD, I'm also contributing to that. So right now, this organization is in the phase of developing a comprehensive community mental health program. So I'm associated with it. Why I attend is that I look forward to develop a model for which can be useful for the city. So since I'm I'm not an expert, but I think both in my research and my practice, attending this course will be of useful.
Thank you. Alkaji, please go ahead.
Good evening, all of you. Good evening, Vibhuti ma'am, and good evening, all my colleagues. Thank you so much for the enriching presentations which were made. Of course, I missed the first one. I'll go through the recording. So my reason being here is I want to connect with wide range of mental professionals. At my personal capacity, I'm mentoring some of the students, and I can see them facing a lot of identity crisis and mental health, and they are unable to get support from anywhere, not even from their family and friends. So they are misguided most of the time. So I feel the need of being empowered, to take care of their needs. Also, in my PhD course, in which I'm doing about education in sexual health, I could see the practitioners and the educationists who are there with me having the same kind of feeling that, what we call it as bloom before you bloom. So Bloom taxonomy, before even you adapt to Bloom taxonomy, you should be blooming mentally, to absorb the learning which is given in the classrooms. So that's my reason of being here. My name is Alka Pagare. I'm working with Kotak Education Foundation as the project head, and we work in the schools which are situated in the slums. So that's also one of the areas which I am connected closely to the students. Thank you.
Thank you, ma'am. Subrasmitha ji, please go ahead.
Hello. So I'm Subrasmitha. I'm working as a research project manager in Swiss Learning Exchange. Gender has always been a very personal topic that I've always been interested on, writing from working on different research and handling different projects on gender, and because I come from a background in sociology, so I was really interested in understanding the different aspects around the holistic level of mental health, talk about best practices, what are different frameworks for it, what is the current reality, and the sessions today were wonderful. Thank you so much. So I'm really I'm hoping for such similar intriguing sessions for the next 2 days as well, and hope all of these help me, the pedagogy helps me in working around different aspects of gender and social sustainability in the future. Thank you.
Thank you. Chitra Ayarji, please go ahead. Till then, I will read out some.
Yeah, good evening.
Yes, ma'am.
Hi, I'm Chitra here from Ahmedabad. I'm working as a freelancer, and I've worked a lot, with the rural and the tribal communities. I was associated with Chetna for a long time. And that's how I first came to know about gender and gender issues and all. And I also for a brief time, I was also, worked in close contact with Poonam Katuria Swati for developing a draft manual for identification of gender-based violence for ASHA workers. So the reason why I am here is, I'm working a lot. I'm taking up assignments on life skills for adolescents, and I also working with rural and tribal women on their health issues. So why I'm here is I would like to know, in the course of this training program, I would like to know, are there any field tested models which can be shared with other people and also understanding, equipping myself with some knowledge, enhancing my knowledge so that I can, share my knowledge with the community women. Thank you.
Thank you. Sasani ji, would you like to go ahead?
Hi everyone, my name is Dr. Saz. I recently graduated as a doctor. I currently work for an organization called Gully Clinic. We are based in Mumbai in 5 different urban slums in Mumbai. And we do a lot of community-based care, a lot of preventive care. And as I've begun to go into community, I think a bit of my bubble has been broken in the sense I get to see women who are going through so much. And I think this course ties in my love for mental health. I hope to be a psychiatrist in the future. And also ties in, I guess, my experiences of working with women in community. And I think will give me a good basis to go forward in my care.
Thank you. Dr. Lovely Srivastava, please, sir, would you like to go ahead? Okay, so they are an assistant professor, Department of Community Medicine, Parul University, Ahmedabad, Gujarat.
Hello, ma'am. Hello, everyone. I'm Dr. Lovely. I'm a homeopath, and so I am very interested in the mental aspect and mental health regarding the gender, how mental health is, how mental health differs in different type of genders, what effect genders put across on the mental health, and as well as I'm working as an assistant professor in Parul University, Ahmedabad. So I'm also interested regarding knowing in the community medicine department. So I am interested to knowing how the different studies are being going on. What are the different factors which are coming across in several type of research studies? How we can proceed towards mental health. And the third point, I am in neuro-linguistic programming, life coach also. So there also I wanted to enhance my knowledge regarding how much of mental health is and how much of gender puts a difference in the mental health problems in both male and the female. So I'm looking forward into this course of 3 days for enhancing my knowledge in the particular 3 fields and getting an insight about the recent changes, recent trends. Thank you so much.
Thank you. Jyoti
Hi.
Devi.
Yes, sorry.
Please, Mr. Ramesh, go ahead. Yeah.
Yeah, hello again. I'm Ramiz Ahmed, and I'm academic officer, and whose main focus is on teacher education and research. So I'm doing independently research on child-centric disaster risk reduction as an emergency management practitioner here in Kashmir, and also I basically work on the areas of social emotional learning, as I discussed earlier with the panelists, experts, and I want to really network and be in touch with the professionals who delivered during the session and learn more about the basics of how to go about from towards being more professional in dealing with issues, especially in the school context, and also extending that to the community level, because we closely work with parents, and I feel the need really to upgrade and upskill myself as a professional in the field. And yeah, looking forward to it. And thank you so much for giving me the chance to listen to and learn from you all. Thank you.
Thank you, Mr. Ahmed,
Thank you,
for
sir.
being so proactive. Thank you. Yeah.
Jyoti ji, please, would you like to go ahead? So I can introduce ma'am. So she's a research scholar, Department of Social Work, Central University of Himachal Pradesh. Shruti ji, would you like to introduce yourself? Okay, again, I'll read it out. So ma'ams used to work with the Women Development and Child Welfare Department of Telangana in the One-Stop Centers of State Projects Management Unit as a senior psychologist. It is during the process of this work that she gained a lot of insight about the rights-based empowerment approach needed to work on gender and mental health. So she's here to gain further insights on the same. Then we have Malvika ji. She worked with an NGO called Breakthrough, and she works on issues of gender, and she's an aspiring mental health practitioner. Atrai Das ji, would you like to go ahead? Again, so she's a fellow with Teach for India, and she's deeply passionate about gender-based violence, education, and mental health, and wanted to explore more about their interconnectedness. Then we have Ms. Purani ji from Chennai, Tamil Nadu. She's a social work practitioner leading a project on the empowerment of women workers in the textile and garment industry in Tamil Nadu. And she also runs a citizen collective called the Pen Collective to promote the socio-political empowerment of women. Then Snehal Rathore ji is a state consultant, UNICEF, Chhattisgarh, for End Violence Against Children and MHPSS. She joined the course to understand more perspectives and availability of academic and expertise resources in terms of gender and mental health to design and roll out programs around adolescent girls' mental well-being at a preventive level. Then Adil Sayedji from Bangalore. So they are a psychology master's student and they have a bachelor's in women's studies. Their reason for joining was to gain more insights into how gender influences our mental health, especially from a queer non-binary perspective. Snehal Neil ji. So she's Dr. Snehal is from Pune, and she works in health and education services, and she's going to work on SEL and mental health for the NGO in Indore. This course is really insightful for the same, and she wanted to, and I will also be starting counseling services. Then we have Shireen Lobo. They're a mental health researcher. They wanted to explore research areas in mental health along with child health and NCDs. They came across this winter school program and hence thought of attending the session. So they're also looking forward to pursuing a PhD and wanted to further expand their knowledge base. Arushi Rawatji, would you like to go ahead? Yes.
Hello, please unmute yourself. Hello.
Hello, ma'am.
Yes.
Yes. Hello, ma'am. I'm Shinjini Roy from Kolkata, and I teach sociology at Dr. APJ Abdul Kalam Government College. I wanted to join this workshop because I want to understand the different perspectives on mental health issue. First of all, and secondly is, I have been working on in the area of social gerontology for more than a decade, and recently I have shifted my focus on dementia, and I have been working on dementia caregiver. I mean, I have started working on dementia caregiver. Their stress, their strains, the fear, the anxieties they are having during this caregiving process. So I thought this workshop would be of great help. So that's why I have joined this program.
A challenging task you have taken.
Thank you. We have Arushi Rawatji. They're a psychology student currently studying psychology for their bachelor's at Indraprastha College in Delhi, at the University of Delhi. They chose to enroll in this course to learn more and gain a deeper understanding of intersectionality in mental health. Then we have Farah Qureshi ji. They are based in Delhi and practicing human rights. They're a practicing human rights advocate, currently working on issues related to legal empowerment and work with vulnerable communities. While working mainly with women from marginalized communities, we see women suffering from different health issues and seeing that they never talk about mental health. So they wanted to get a better understanding on the same. Then we have Sangeeta Sengupta ji. They're currently pursuing a master's in sociology and social anthropology from Tata Institute of Social Sciences, Guwahati. My course is more theory-based and they wanted to gain insights into community level and ground level reality of gender and mental health from diverse practitioners and experts in their respective field. So this is also an opportunity to upskill themselves and learn before they start research and work on the field. Then we have Nihalika Yadavji. She's a postgraduate in political science from University of Lucknow and is now preparing for civil services. And the reason that she chose to join the course was because she herself had suffered abuse and trauma, so wanted to gain more insight, and also felt that this could be a platform where she could share her story. That would be heard with utmost sensitivity.
Thank you for trusting us, Niharika.
Yes, thank you.
It's quite
Then
humbling.
we have Samprikta Dattaji. This is their 4th year in the field of mental health, and they're primarily working with children and adolescents in an inclusive setup. They have worked as a psychologist and faculty for undergraduate psychology. They're currently based in Hyderabad, where they're working as a school psychologist. As an intersectional feminist, their inclination towards gender, caste, sexuality, and ability intrigues them to explore more in various mental health aspects of both clients and students. Then we have Jaya 3G. They're a PhD research scholar at Department of Social Work, University of Delhi, and they wanted to have a greater understanding of mental health and its related concept. Lastly, we have Mala Ji. They're a project coordinator at VACHA, and they're in a close sphere of girls supporting them in the educational stream, looking after their nourishment and requirement. So they wanted to gain a greater understanding of mental health in through this session. Thank you all for joining us today. We are truly grateful to all who've been part of today's event. If there are no more introductions, I will move. Ma'am, would you like to give your closing remarks?
Yeah, in my closing remark, I would just like to summarize the important, so many mind-boggling issues have been discussed in our expert resource persons, Professor Manjula, Dr. Aparna Joshi, and Dr. Meenu Anand. They have a long years, like nearly 4 decades of their ground level experience. And based on that, they say that the psychosocial stressors originate from the external social environment. I think all 3 of them emphasize that. And women's inferior social position, lack of power, homelessness, economic hardship, man-made or natural disasters, all of them contribute to mental health challenges. They create learned helplessness also, as I think so many of you in your introduction also said that when you are while working, women's seemingly passivity during the crisis such as domestic violence or the accident is mainly because they know that nothing is going to, the sheer helplessness that nothing will change, no? So that kind of hopelessness and generating helplessness. So it reduces motivation to lead an active life. Stress-related mental health issues are economic hardships, illness in the family, death of one's spouse, divorce, accident, that might reduce or your overall capacity or ability to shoulder inability to shoulder responsibility. Or after marriage, women get displaced because it's a patriarchal society. So after marriage, women get displaced from which brings about a cultural loss, bereavement, loss of social networks, loss of social support, loss of traditional healing sites which they had in their natal family. The protective shield that they had. Psychological stages through which women pass are enduring, suffering, reckoning, reconciling, and normalizing. All the examples given by 3 experts showed this whole journey of women and the gender minorities. The successful completion of therapeutic cycle depends on how conducive the physical and emotional systems are, whether they are within the mainstream medical services or in the alternate healing processes. And hysteria can also open up more opportunities. I gave the example of women's movement, that how during the 80s and 90s, when the whole gender-based campaign against rape, campaign against sexual violence, campaign against domestic violence, brought out the collective hysteria. And that was also very empowering because it increases the freedom and the space, which with an added cost, because you also get known as a firebrand feminist. But whatever you may say, you may hate feminists, you may like feminists, but you can't ignore feminists. And whatever issues, they were the ones who brought out the whole issue of violence or the challenges that women face in the public domain. Otherwise, it was always treated as a personal problem. So women cope up with tension by crying or talking it over or praying or engaging in creative work, music, art, work, singing, therapy, and also community work and the team building. I think the Aparna Joshi, so many examples she gave. So the depression which manifests in headache or sleepless night or constant contention, detachment, irritability, loss of appetite, dryness of mouth, fear, self-blame, lack of concentration, lack of interest in any kind of activity. We have seen it all around in our families, in our friend circles, in our neighborhood. And although chronic headaches may not be psychosomatic, but they can be caused by depression and anxiety. So although chronic headaches may not be we need to understand them as a manifestation of what is undergoing in their personal life. So counseling can help you identify and address emotional concerns. They should be considered as a part of the treatment. And that is what all three speakers say, that biomedical stressors, which are only talking about the hormonal fluctuation and genetic reasons. I think that is very inadequate way of saying, or even talking about the PMS, premenstrual symptom, or a postpartum phase. So that they are stressors, but I think that we have to locate them into the socio-cultural and economic environment, whether it is enabling or disabling. So women's movement has provided fresh inputs in terms of individual and group counseling, popularly known as consciousness raising exercise, a form of mutual counseling that enables women as a group to share experiences, problems, feelings, dreams, utopia, action plan for rebuilding the shattered lives. This process of attaining feminist consciousness allows women to recognize what they perceive as a personal problem is shared with others in a non-threatening and non-power-oriented atmosphere. It also enables women to realize what they think as a resulting of living in a patriarchal society. Consciousness raising enables women to overcome false consciousness that I am inferior, I don't know anything, I have phobia, I can't go out on my own. All these are false consciousness. It empowers women to come to a realization that of their own potential, makes them autonomous, self-dependent in their decision-making power, and emotionally self-reliant. It is an ongoing process that brings about personal and collaborative change as opposed to structural change. The need for small groups or informal group discussions is emphasized in this method, and concerted effort at social, political, economic, legal levels can bring change in the lives in the, those who are suffering, and contribute to the improvement in the mental health of all those who are facing mental health challenges. And the question of common mental disorder, which is unexplained through the body-based symptoms, I think that can also be cured by this kind of a community-based program. We have an organization called Family Service Center in Mumbai, and it's a halfway home for the elderly people, because elderly people in a city like Mumbai, they are always unwanted. There are small flats. Nobody talks to them. Everyone is busy. And when they come to this halfway home, they share their experiences. I can share my own experience of being in Women's Center when we were full-timers. So many women who were trafficked, who were child, especially those who were child sex workers, or women who had lost their speech because of extreme form of violence. When they started attending the get-together of women with a similar circumstances, and when we had a painting workshop and we had a song workshop in which women who never sung in their life, they also started giving words for the song. And I would like to end with those verses. Jharna gaye, ped bhi gaye, aur main kyun na gaun, sur mein bolun, lay mein bolun, panchi ban ud jaun. And this is what there's quest for freedom, their quest for a life full of peace and harmony, and the support and solidarity that was expressed in those verses. And it was a group activity. So I think various types of healing therapies that we have, I think about that also in the coming 2 days, practitioners will discuss with us. And thank you very much for being so proactive and so engaged in all the sessions. Thank you.
Thank you
Yes,
so
ma'am.
much, ma'am, for sharing your expertise and insights with all the participants today. We have just two more introductions. So we have Cicilia MKG, a research scholar from the Department of Women's Studies in the University of Calicut. They're a researcher in the field of women and mental health, and also recently submitted a PhD thesis on women and mental health. So they're interested in the area of mental health and wanted to gain new knowledge in the same. Then we have Tamagni Dasji. They've submitted a PhD in the School of Gender Studies in Tata Institute of Social Sciences, Hyderabad. They've also done their MA and MPhil in Gender Studies from TIS, and which explains their interest in the field of gender. The reason they chose to join this was mental health is very personal to them. As a caregiver to their father, who was a patient and victim of depression and frontotemporal dementia for 6 years, they finally lost life to suicide, and they see this 3-day immersive session as a way to learn how to cope as a woman with such stressful situations and learn and unlearn about different dimensions of mental health. Thank you for joining us today. We're grateful to all who've been part of today's event. With day 1 coming to a close, we eagerly anticipate your return for day 2, where we have presentations by Dr. Cicilia Chettiar, Professor Anuradha Sovani, Professor Mala Ramanathan. Thank you, everyone. We will also be sharing a participants list with all the participants. As we come to an end of day 1 of Gender and Mental Health, an online international winter school program, a 3-day immersive online certificate training course, I, Ramanathan Arora, researcher at IMPRI, Impact and Policy Research Institute, would like to propose a formal vote of thanks on behalf of IMPRI Gender Impact Study Center, New Delhi. We are grateful to our experts for day 1, Professor Vibhuti Patel ji, Professor M Manjula ji, and Dr. Aparna Joshi ji and Dr. Meenu Anand ji for taking out their valuable time and giving an opportunity to the participants to learn from this online certificate program. We thank all of our participants who have raised pertinent questions and actively participated in today's deliberation. Readings for the session have been shared in your email, and a video of the session will be shared with you for learning. We look forward to welcoming you for the second day of this certification course on 14th February at 6 p.m. We are grateful if you're watching us later on YouTube or listening to us on our various podcasts or reading our publication. We hope you continue to join in future to our IMPRI Web Policy Talk and Web Policy Learning. Wishing you a good evening. Thank you.
Thank you, Ramat. Excellent anchoring. Thank you.
Thank you, ma'am.
Fabulous. Thank you.
Thank
Good night.
Thank you, participants. Yeah.